Yesterday was filled with wonderful discussion, shared experiences, laughter, nostalgia, and meaningful learning. And today we continue this journey with yet another exciting lineup of sessions designed to inspire curiosity, collaboration, and professional excellence. They say conferences are not just about lectures and presentations. They are about conversations that spark ideas, people who inspire growth, and moments that stay with us long after the event ends. And looking around this hall, hopefully, I can confidently say that we are surrounded exactly by that energy. We began this morning with a registration and breakfast, and now I hope that everyone enjoys the opportunity to reconnect, meet new professionals, and start the day on the refreshing note. Coming to our main agenda, it's now time to dive into our first academic segment of the day, which will be scheduled for 9:30 to 11. For the audiology track, we have an intriguing and clinically relevant session titled Dilemma in Diagnosis of Vestibular Disorders, which will be facilitated by our own Dr. Sharda Sarda, along with Mr. Swarup Mishra, Ms. Vidhi Loda, and Mr. Sahil Sheikh. Excellence in academics and research becomes truly meaningful when it inspires future professionals and transforms patient care. It is my proud privilege to introduce our esteemed speaker, Dr. Sharda Sarda. Dr. Sharda is serving as the professor and head of the Department of Audiology at Bharati Vidyapeeth School of Audiology and Speech Language Pathology. She has been a distinguished resource person at various national and regional conferences and has actively contributed as a member of ethical committees and PhD committees across universities. Her remarkable academic journey includes receiving multiple Best Paper Awards and leading an ICMR-funded project in vestibular assessment and management. Her key areas of interest include vestibular assessment and management, as well as speech perception, and she has contributed extensively to the field through numerous national and international paper presentations and publications. Ma'am's dedication towards research, teaching, and professional excellence continues to inspire students and clinicians alike. So everybody, please join me in extending a warm welcome to Dr. Sharda Sarda for her insightful session.
Okay, so very good morning to everybody and thank you for such a nice introduction. So we are going to have a session of 1.5 hours on vestibular assessment. We have specifically thought of positional vertigo and how to, it may sound that it's just a positional vertigo, but there are multiple possibilities that can occur in the positional vertigo. So we hope that through today's presentation, we highlight you people and develop interest and confidence in treating the patient with positional vertigo. So today's first speaker is Mr. Sahil Sheikh. I welcome Sahil Sheikh. He has been actively involved in doing vestibular research. He has done his dissertation also in vestibular, and he is continuing to be an expert in the vestibular disorders. Now our next speaker is Ms. Vidhi Loda. I welcome Vidhi. She has worked in vestibular project. She has been our alumni and has been doing research in the vestibular disorders. And currently where she is working, also she is actively taking clients with vestibular problems. And now we have Mr. Swarup Mishra. I think he is known to many of us. He is one of the pioneering person, I would say, even at Bharati Vidyapeeth when he was there at Masters with us. He also developed the interest among us, and that is how we also started. So I really feel very proud to have him here. I'm sure he is going to give us a lot of insights, and whatever presentation he is going to talk is not enough, that you will realize. But this will be one of the one of the step towards learning, and I'm sure you will start developing your interest in it. So I welcome Swaroop. He has been one of the audiologists who has been working very, very actively at national and international level, advocating about audiologist's role in vestibular disorders, and through his continuous work that he is doing at his different clinics, he has his own 3 branches, and he is very, very active in vestibular disorders, not just treating, but he is also doing a lot of research and going and conducting a lot of fellowship program. So I really welcome you, Swaroop, and very glad to see you here. So we will start with the presentation, first presentation with Sahil. Yeah, Sahil, please come ahead.
Good morning, everyone. Thank you so much, ma'am, for the great introduction. So now, first, in this session, I'll be starting with the understanding BPPV fundamentals for the clinician. First, we'll see what is BPPV. So B stands for benign. So we know that it is not life-threatening. That's why it is benign. Then paroxysmal. It comes sudden and brief spells. So whenever there is a complaint of brief spells, there is a possibility of BPPV. Then positional. So positional stands for it gets triggered by the certain head positions or movement. So specifically patients will say that whenever I am waking up or whenever I am turning around, I am getting the vertigo. Then last stands for the vertigo, that is a false sensation of rotational movement. Actually the patient is not moving, but the patient is feeling that he is moving. So why it happens? Because in the inner ear we have 3 semicircular canals. Here we can see. Hello. This is the anterior semicircular canal, this is the posterior semicircular canal, and this is the lateral semicircular canal. Here is the utricle. So what happens? Because of any reason, in the utricle there are otoconias. Here we can see there are the otoconias on the otolithic membrane. Because of any hormonal issues, any sudden jerk or the head injury, these otoconias get loose from the otolithic membrane and they falls into the semicircular canals. So what we can see here, because of the gravity, this is the posterior canal, and because of the gravity, whenever the otoconias are going to fall, the most probability it will be falling in the posterior semicircular canal. And that's why when we see the anatomical classification of BPPV, the posterior canal cases are mostly 80%. Then the second chances are in getting to the horizontal canal, and the least chances are of getting it to the anterior canal. So now what happens when these otoconias get into the semicircular canals? So there are 2 possibilities that explains the pathophysiology of the BPPV. So one is canalithiasis and second is your cupulolithiasis. Now we will try to understand what is canalilithiasis and what is cupulolithiasis. So this is the semicircular canal, and in the semicircular canal there is a free floating otoconia. So now whenever there is a head movement, what will happen? This otoconia is going to move with the endolymph. So whenever there is a solid particle in the fluid, it will change the specific gravity. And because of this change in specific gravity, the fluid that needs to change the potentials in the cupula, it will not be able to sense that. And because of that, there will be a false sensation in the cupula because of this moving particle. And that's why in the canalilithiasis, the patient will feel the vertigo. But now what will happen in the cupulolithiasis? Now here we see the otoconia is getting adhered to the cupula. Now directly the specific gravity of the cupula is getting changed. And whenever there is a sensation, the cupula will not be able to move as it is supposed to move. And because of that, there will be the false sensation of vertigo. But this is the anatomical part. But how you will see it in clinics? So you will see in type of nystagmus how it will be differentiated. So if you see the canal ilethesis, it will be the latent onset. Like as soon as the head is moving, after 5 to 20 seconds, you may see the nystagmus or the perception of vertigo. Why it is happening? Because as soon as you are moving the head, it will take some seconds to move the otoconia. And that's why you will see the latent onset in canal ilethesis. Then short duration. Because as soon as the otoconia, which is in the semicircular canal, it will stop moving. Okay, so then the false perception of vertigo will also stop. Then crescendo, descendo intensity. Why this happens? As soon as the otoconia is moving, it will start the false perception of vertigo. But as soon as the otoconia is stopped, it is there at the place. There is no movement in the semicircular canal, then it will stop the false perception of vertigo. So it will increase the perception of vertigo, then suddenly. Hello. But what will happen in cupulolithiasis? But what happen in cupulolithiasis? The otoconia are getting attached to the cupula. So because of that, there will be the immediate onset. As soon as the head is moving, the cupula is not getting the proper sensations, and that's why the patient will be feeling the vertigo. Then persistent duration. Because it is adhered to the cupula, whenever the head is still moving or in another direction, there will be still the sensations, and because of that, the patient will feel vertigo. Then fatigability is less common. That means as soon as the nystagmus starts, what we see in canal ilethesis, it gets fatigue. The nystagmus intensity gets gradually reduced. But in cupulolithiasis, it doesn't happen because the cupula is adhered with the otoconia, and that's why it continuously get the sense of false vertigo. Now I am talking about continuously about the nystagmus. So now we will see what type of nystagmus and how to observe the nystagmus. So first, the nystagmus is a vision condition in which the eyes make repetitive, uncontrolled movements. These movements often result in reduced vision and depth perception and can affect the balance and coordination. So whenever there is a incoordination between your visual system and your central nervous system, there will be the uncontrolled eye movements that will be result as a nystagmus. Hello. So now, here if you see, this is the example of a left-beating nystagmus. Whenever there is a nystagmus towards the fast direction, it is called as its direction. That means if we see left-beating nystagmus here, that means the fast phase of the nystagmus is towards the left. These are the eyes. So now whenever you are observing the nystagmus, first you should observe the pupil. If you are not able to observe the nystagmus from the pupil, observe the eyeballs. Okay, because you will be always getting the reflections there. So by observing the pupils and overall eyeballs, you will be able to see where is the fast phase, where is the slow phase. So now if you see here, the eyes are going fast towards the left side, then coming slow towards the right side. Fast towards the left side, slow towards the right side. That means this is a left-beating nystagmus. Now, here you can see the example of up-beating nystagmus. First, see the pupil. And if you are not able to observe with the pupil, you see whole eyeball. The eyes are moving first, fast, in the upward direction, then coming slowly towards the downward direction. Fast towards the upward, slowly towards the downward. That means the fast phase is towards the upward direction. That means it is a up-beating nystagmus. Then this is the torsional nystagmus. If you are dealing with the vertigo, dealing with the BPPV specifically, most of the time you will be seeing this. Okay, so now in the torsional nystagmus there are both components. One is your horizontal, one is your vertical. We have seen the horizontal component here. We have seen the vertical component here. Now this is the combination of two. First we will see the vertical component. So now if I observe the eyeball, I can see the eyes are moving upwards. The fast phase is towards upwards and slow phase is towards downwards. But what I can see, the eyes are moving like this. So the vertical component is towards upwards, but the horizontal component is towards left side. So this is a torsional nystagmus where there is a upbeating nystagmus as well as left beating nystagmus. I can also say that as a clockwise nystagmus. So I hope till now you have cope up with the nystagmus, and as you practice, you will be able to analyze it very easily. Now here if we see, this is the table where you can assess and manage. Using this table you can assess and manage your BPPV patients. So before this, to explain this, I would like to invite a subject so that we can have a better idea. So the first we will see the posterior semicircular canal. The provoking maneuver is Dixol-Pike. Okay, so this is the classic Dixol-Pike maneuver that we will start with. So first what you are supposed to do, you are supposed to instruct the patient that you will be doing, you are supposed to instruct the steps that what you are going to do and tell them that they will be feeling some seconds of vertigo at least. If it is more, just they are supposed to tell you. Then before starting with the case, you are supposed to tell them to lie. You are supposed to check that if the head is in hanging position, because you will need this. Okay, just keep in mind that you need this head movement at the time of assessment. Then you tell them to sit, and now we will start with the assessment. So if I am testing for the left side Dixol-Pike, I will turn 45 degree. Okay, then I will go to the supine position. I will observe the nystagmus. I will come to the sitting position again. Left side, then. So now what you are supposed to see, you are supposed to observe the nystagmus at each step. What will happen that if it is a canal ilethesis, there will be a latent period of around 5 to 20 seconds. So you are supposed to wait at least 30 seconds to get the nystagmus. If after 30 seconds there is no nystagmus, yes, you can go for the other step. But if you see a nystagmus, you are supposed to observe the direction, and as soon as the nystagmus gets suppressed, you can go for the other step. So in posterior semicircular canal, you will be getting the upbeating and torsional towards the affected side. Okay, so in the last example, we had upbeating and torsional towards the left side. So that means it is a left side posterior canal BPPV. So affected side will be the torsional towards the affected side, and treatment we go for, if we talk about the posterior canal, the treatment is Epley's maneuver. Now if we see about the anterior semicircular canal, in Dixol-Pike itself you can diagnose the anterior canal BPPV, where you can see the downbeating and torsional towards the affected side, and always in posterior and anterior canal, the torsion towards the affected side you will get. And to treat that anterior canal, you have the Yakinovo maneuver. There is one more maneuver to diagnose the anterior canal. If you want to, it is a deep head hanging maneuver. So in that, what we will do, the patient is in the sitting position, then you tell them to come to the supine position. Okay, now here you are supposed to go till like this, around 30 degrees. This is the deep head hanging maneuver. Then in the chin tuck position, in these two positions you are supposed to observe the nystagmus. After that you can come to the supine position. The diagnosis remains the same, downbeating and torsional towards the affected side. Wherever there is a torsion, it will be the affected side. Now if we talk about the horizontal canal, so in horizontal canal we are going to use mostly the supine roll test. For the supine roll test, what you are supposed to do, first step is the chin tuck. By doing this chin tuck, you are getting into the plane of the horizontal canal. Then go to the supine position. Neck loose chodo. Loose chodo. So this is the thing. What happens when you do the chin tuck? The patient will take the neck control. Okay. And during the position, during the maneuver, if you don't tell them to lose the neck, it will be painful for them. So you just tell them that lose your neck and give them the support by your hand around 30 degrees. Okay. Then we will do it for the right side. Then right to neutral, then neutral to left, and then left to neutral. Now what you are supposed to observe here, that when you are doing the supine roll test, you will be getting two types of nystagmus. One is your geotropic and one is your apogeotropic or ageotropic. So when I am turning the head towards the right side, and if the nystagmus is towards the ground, it is geotropic. Okay? And if it is a geotropic, it is a canalilethesis of the affected side. That means when I am turning towards the right side, nystagmus is towards the ground. That means right canal, canalilethesis of horizontal canal. But what if happens, I am turning the head towards the right side and I am getting above the ground, that is ageotropic. So that is your cupulolethesis of the right semicircular canal. So it is very easy if you can observe the nystagmus. So just remember, whenever you are observing the nystagmus, first try to see the pupil. If you are not able to observe the nystagmus by pupil, observe the eyeball and the reflections on that. So that you will, by that you will be able to analyze the nystagmus very properly. There is one more maneuver, that is bow and lean test. If you are confused with the cupulolethesis and canalilethesis, you can test that too. For the horizontal canal, the canalilethesis, we give the maneuver, that is 270-degree roll, or the Apneni maneuver that we say. And if you see the horizontal canal cupulolethesis, the treatment is with the Cassani maneuver. These are some complex clinical variants that you may see. First is your bilateral BPPV. Sometimes it gets confused while you are diagnosing, and sometimes it gets confused while you are treating also. Like which side you should go first. So that will be the case where you will see the bilateral BPPV. Then subjective BPPV, where during the Dixhall pike, the patient will say there is a vertigo, but there is no nystagmus. So this can be because of the long-standing BPPV, and there is a central compensation. In that case, you will see the subjective BPPV. Then if we talk about the recurrence, that we mostly see in the 15% of the cases, where the patient is treated and they are getting again the vertigo. So this can be in two cases, that the autoconias are again getting into the posterior canal, and one variant is the canal switch, where you are treating the posterior canal and autoconias get into the horizontal canal. Okay, so this is the case of recurrence. The last thing that I would like to mention, that is your metabolic and systemic disorder. That vitamin D3, there is a strong association with BPPV has been found. So whenever there is a case of BPPV, we are supposed to ask them about their vitamin D3 and B12 levels. But vitamin B12 deficiency does not cause the BPPV, it actually mimics the BPPV. Okay, so we are giving the manures, but the patient is not improving. Actually, it is because of the vitamin B12 deficiency. So whenever we suspect any metabolic disorder, we should go with this vitamin D3 and B12 considerations. These are my references. Thank you so much. You were a great audience. Thank you. Now I would call Miss Vidhi.
Am I audible? Yeah. So thank you everyone for attending the lecture. Sahil has given a very good introduction to BPPV and what you might see in your clinical experience. Let's just see through few case studies and what could be the clinical findings that you might see when you are approached by a patient for a vestibular evaluation. Now, keep in mind what all Sahil has already spoken about in his presentation. You'll come across all of that. Okay. So again, I'll just do a small recap. On the basis of the canal involved, we have posterior canal, horizontal canal, and the anterior canal BPPV. And that is in the order of the most common and the least common type that you might see in your cases. In the posterior canal BPP, you will see a torsional nystagmus, which will be upbeating, and the torsion side is going to tell you which side is affected. The horizontal canal, you will see a purely horizontal nystagmus, which can be either geotropic or apogeotropic. And the anterior canal, where you might see a downbeating nystagmus. The downbeating nystagmus may or may not have a torsional component. If there is a torsional component, it will guide you which canal is affected. Just again, horizontal nystagmus, it's a leftward or a rightward beating nystagmus. Vertical is up or down, and a rotatory or torsional nystagmus is where there is a mix of both a horizontal and a vertical component. Okay. Now let's look at this first case. This is a female, 50-year-old female, which came with a complaint of episodic vertigo, which is lasting 1 to 2 minutes since the last few months, and it has been intermittent. Now the spinning sensation is associated with a sudden change in position whenever she's sleeping. Now she already has a previous diagnosed history of otosclerosis with reduced hearing in both the ears and tinnitus in also the right ear. She has diabetes since 30 years. She also complains of neck pain. Considering the age, we can associate that with postmenopausal changes. And again, patient has low B12, D3, and hemoglobin. So we need to keep those things in mind when we are diagnosing a patient. When you do the whole evaluation, we'll start with the VNG assessment, where you rule out any other central component. So you'll do the saccade test, you'll do smooth pursuit test, gaze test, and the optokinetic test. When you see there is no other involvement, no other central involvement, then you'll move to the positional test, because there is a complaint that it is triggered by certain positions. The first test, since we come across posterior canal BPPV the most common, the first test will always be Dix-Hallpike, and then you can do the McLeod-Paganini or the supine rule test. So now we started with the Dix-Hallpike test we did for the left and the right side. I'm starting with the left side for this patient. And what we see here, I hope, as Sahil suggested, you look for the pupil movement, and if not, you see the reflection on the eye. Okay. I've cut down the videos to the provoking section of the nystagmus. And I hope you can see the torsional movement. There's an upbeating component, and there's also a leftward rotation of the eye. It came, and then it has also slowed down. Now you do the left side, and then you move to the other side. Now, since the patient is going to experience vertigo, you might see that they have a lot of blinking. They're trying to compensate for the disturbance that they're feeling, the sensation that they're feeling. And it might make it difficult for you to visualize the vertigo, but I'm sure you could see that there was a rotatory movement towards the right side, in the right side Dix-Hallpike also. Now, in very few cases, you will see that when you do the supine roll test, you might see the torsional component, which is coming from the posterior canal, coming even when when you're testing the horizontal canal. And I've brought this video here because I could see much clear torsional nystagmus in this particular test. So here you can see that there is a rightward torsional movement on the lateral, and then we come back to the center. There's an upward and an anti-clockwise movement for the right side. Then you come back to the center. Where it's still persisting. Now, as soon as we came to the left lateral, we are able to see a torsional component which has switched to the left, going in a leftward movement, so a clockwise movement of the eye. Now, in such a case, we can, as Sahil mentioned, there can be cases of a bilateral BPPV also. It could be a case of both the left and the right posterior canal which is getting involved. So, and there are multiple studies which have mentioned that if we see such a case, you can start, it can be a case of actual bilateral, or it can be a case of one posterior canal which is affected, but you see the effects also on the opposite side. So what they suggest is always start where the nystagmus is more stronger. And if you see that, okay, the vertigo has subsided completely, then we can confirm it was only unilateral BPPV. Or if you see that the vertigo is still persisting on the opposite side, then we can confirm that it was a bilateral BPPV of the posterior canal. Now, in this case, it was diagnosed as the left posterior canal BPPV. Even though the nystagmus was seen on both the sides, the left side disc hall pike had a stronger nystagmus velocity and frequency. And only the Eppleys on the left side relieved her of all the symptoms. Now let's look at the second case. She is a 49-year-old female. Again, she came with an episodic positional vertigo complaint, which has been there since one day, and it lasts around a minute. And this gets triggered again whenever she lies down on the right side. This patient had initially gone to the ENT. The ENT had already given her an Eppleys maneuver before she came to us. There was no complaint of any tinnitus, hearing loss, or block sensation in the ears. She is in menopause right now, and there has been a similar incidence of vertigo in 2024 and 2025 also. Now, this can be a case of reoccurrence, as mentioned. Let's look at the Dixol pike done. I would like you guys to tell me what you see in this case. Is it an upward or a downbeating nystagmus? Anything that you can see? Is it a clockwise? Is it anti-clockwise? Yeah. There's an upward component, yes, it's torsional. Which direction would you say? Right, yes. So we are seeing a rightward movement. It is anti-clockwise. Think of a clock in front of you. If it is going from 1 to 12, it is clockwise. If it's going backwards, it's anti-clockwise. Just think of this as a clock, and you can see that. So you can see when we came to the provoking position, after just 2 seconds, we can start seeing the torsional component. It is going anti-clockwise. It has started fast, and then it is slowing down pretty soon. So you can see the crescendo and descendo motion of the nystagmus also here. Now, I've not shown the other side because in the left side we did not see any nystagmus. I've kept it concise for the case. Now, let's look at this third case. This is a 33-year-old male which had a complaint of vertigo which was continuous 2 weeks back. Now, with the present history that he showed, which was, it started 2 weeks back, it came as a case of vestibular neuritis. He went to the hospital immediately, he got an MRI done, and it was ruled, any central causes were ruled out. The neurologist ruled out any central causes. Then, since last 2 weeks, the vertigo has become episodic and is triggered whenever he is bending down, looking up, and sleeping on the right side. Each episodes last around 5 to 6 seconds. There is nausea when he gets up in the morning, and there's some heaviness in the head and the ear during the vertigo. Okay. Again, I would like you all to tell me what you see here. What do you guys think? So what we expect from a Dix-Hall pike is, if we want to consider it positive, we want to see that torsional component, which we are not seeing here that strongly. We'll move on to the other side. We'll just consider it as at negative right now. Okay. What can you see here? Think of the upward, downward motion, left and right, all the directions. So again, there's not a very clear torsional component. It's very mild. It's not easy to detect if it's there or not. So we did, after Dix-Hall pike, we considered both of them negative right now. We moved to the supine rule test. We did not see any nystagmus on supine rule test. So we moved to the anterior canal testing. So we did the supine straight head extension test. I hope you can appreciate the vertical component of the nystagmus right now. Can you tell me which direction it is? Yes, there's downbeating nystagmus. So as we had discussed before, in the anterior canal, you will see a downbeat nystagmus. The torsional component may or may not be visible. If it is visible, you can tell which side is affected. But the good part about anterior canal BPPV is that the maneuver that we have, it treats both the canals simultaneously. So even if it's the right or the left, you have to do the same maneuver. And if you see a resolution of the vertigo of the nystagmus, we can be sure that it was the anterior canal which was affected. So as what we saw for this case, we could not determine which anterior canal was affected. There was not a very clear torsional component. We did the maneuver and we could see that the vertigo had resolved immediately after the maneuver. Let's look at this fourth case. Now this is a 74-year-old male who has been having episodic vertigo since 2 months, triggered whenever he's sleeping on and getting up from the right side. Now this patient has given a very specific direction also where he's feeling it. You always have to ask in the case history which specific position it is happening, if it's happening more on one particular side than the other. The Epley's maneuver was again done previously, but the dizziness has still persisted. There are no neurological signs or symptoms. He has been to a neurologist before this, and there is no complaint of imbalance or walking or during any general daily activities. So any central causes are also mainly ruled out. Let's look at the Dix-Hall pike again. I'm sure he was blinking a lot, so it was a little difficult to see it. But the intensity of the nystagmus made it very clear to see where it was. And again, you can see that it was very intense. It was not there. It had a very sharp, intense, and then it slowly went down, and it has almost stopped now. I'll just play it again. There's a very strong upward and anti-clockwise or a counterclockwise torsion, which we would see for the right posterior canal. Again, he's feeling a lot of vertigo, so he's been blinking a lot. And rest of the tests were all negative. He was treated with Eplase for the right side, and the vertigo did resolve. Now let's look at this one last case. This is a 40-year-old female. She came with the complaint of episodic vertigo, which has been there since 3 months, and it occurs whenever she lies down, bends, or looks up. Each episode lasts for around a few seconds to about a minute, and there is no complaint of any nausea or vomiting. Again, there is a complaint, there is a case of low hemoglobin and vitamin D3. Now, vitamin D3, as mentioned by Sahil, is a very common cause, I can say, or it is very commonly associated with BPPV, that if there is a low D3 for a very long time, there is a high chance of BPPV. And again, in postmenopausal women, there is again a very high chance of BPPV. Okay, let's look at the Rixolpide. Can you tell me what you see here? I would like someone from behind tell me. Mihir has been answering. Can you see any torsional component, what you would expect from a Dix-Hallpike? So we are not seeing any torsional component here, but we could see some nystagmus, which probes us to see that, okay, let's do the testing for the other canals also. On the right side, there was no nystagmus at all, so I've skipped that. And we come to the horizontal canal. So we move to the right first, then neutral, then left, and then back to neutral, and then we sit back up. So on the right, you could see a right horizontal nystagmus. It was a very clear horizontal nystagmus which stopped after a few seconds. We come back to neutral and it's not there. So now there might be cases where the patient is just moving the eyes a lot here and there. And you have to cancel that out and see the nystagmus purely where it is. Now when we turn to the left, so there is no torsional component to it. There is a purely left beating nystagmus also on the left side. So now again there is, we have to see if it's a bilateral horizontal canal BPPV or if it's just a unilateral BPPV. Again, you would do the maneuver for the side where they feel is more stronger, where they feel the vertigo is more stronger, or from your testing where you see the nystagmus is more stronger, and then you select which side maneuver you want to do. Unlike the anterior canal, the maneuvers will be different for the anterior and the posterior canal. The posterior and the horizontal canal, the maneuvers will be different based on where it is. And you select the maneuver, you do the treatment, and based on which it is resolving or not, we can determine if it's a unilateral or a bilateral BPPV. Thank you. Now, these are just the very typical and very straightforward cases of BPPV that you will see, but there are a lot of mimics of BPPV. Let's have Sir just talk about that more in detail now. Thank you. Over to you.
Okay, thank you so much. It's there? Yeah. Thank you so much. First of all, I would like to give thanks to our organizing committee who has done a best work, like make a alumni conference like this never happened in any institute what I have seen. And also our faculties always behind our students and with alumni. So I'm here. It's a privilege and proud moment for me that standing here with in front of my teachers and sharing my ideas, what I'm doing in my clinical practice. So we'll be discussing about beyond typical BPPV. What I understood right now that you people have understood what is BPPV, right? So BPPV stands for benign paroxysmal positional vertigo. So let's start with a discussion on positional vertigo. Is BPPV is a positional vertigo? Yes. But all positional vertigo is a BPPV? No. Good. So you got the idea. So now you will see many patients who's looking like BPPV. You tried lot of maneuvers, but again and again the patient is coming after 4 days, 5 days, ma'am. No, it's not happening with me. Same intensity, same all these things. And you'll be lot of confusion in between that, what is the case? So now try to understand typical BPPV means what they have given the presentations about posterior canal BPPV, anterior canal BPPV, lateral canal BPPV. But when you are doing, you are thinking it's a BPPV, you are doing lot of maneuvers, but when you are not getting success, then think differently. Okay? So I already discussed what is positional vertigo. So please remember these 6 positions: sitting to supine, supine to sitting, bed, right side, left side turning, bending forward, looking up, looking down. If is 6 position they are getting vertigo, that means it's a positional vertigo. Now let's talk about BPPV as they have discussed about which test you are going to do, what kind of maneuver you want to do. That's a separate topic. Now just tell me, okay, already they have discussed about all these things. I will not go through epidemiology, causes you know. Now you see, always BPPV is spontaneous and many times it's a idiopathic cause. You don't know what is the exact cause behind that. But if it is a secondary BPPV, that means they have a labyrinthine disorder like Meniere's disease, vestibular neuritis, idiopathic sudden hearing loss, any kind of labyrinthine disorder first. After a few months or few days, they will have a BPP kind of symptoms, and that is called secondary BPPV. Clear? Now, if you will consider about bilateral or multiple canal BPPV also sometime, then just go behind your history properly. If they have a head trauma, then you consider it as a multiple canal or bilateral BPPV. Many times I have seen people are writing bilateral, left side geotropic, left side, right side, bilateral, it's that. It's not like that. If the history is not like that, it is not. Okay? So many times it's unilateral. But when you're considering bilateral, multiple canal involvement, then please think about head trauma, any history, go for the history first. Next. Now tell me, is the name justified? Benign paroxysmal positional vertigo, is the name justified? If you go through literature, somewhere it is written positional, somewhere it is written positioning, yes or no? So don't think all the old history. Now it is accepted, well established by Barana Society. BPPV stands for benign paroxysmal positional vertigo. No position, no positional, don't be confused about that. Okay? And just tell me, is it the problem in the semicircular canal or in the utricle? Semicircular canal? Utricle? Backside? Semicircular canal? Okay. Just I am giving a funny example for that. Okay. So, if you are sitting in your home, watching IPL, and suddenly one snake came into your house, then what will do? Or you will shout, that means you are abnormal? No. Autocornea loses from the, dislodged from the utricle. Semicircular canal is fine. And that autocornea came into semicircular canal, disturbing all these nystagmus. So problem not in the semicircular canal, problem in the utricle. And when you are calling the snake catcher, please I have a snake in my house, please come. When the snake catcher is coming and searching that snake, where is the snake? That means what you are doing? You are doing test, which canal autocornea is. And when the snake catcher got the snake and trying to release that snake in their habitat, that means you are doing the maneuver to release that autocornea from that semicircular canal and trying to send it back to the utricle. So this is all about. So you can see this picture. It's just a fun game you people have done in childhood. Now tell me, BPPV is a peripheral or central disorder? Peripheral, very good. Now, if you have treated BPPV, but you are not getting any clue, then what to do? You think about CPPV, means central paroxysmal positional vertigo. And many literature, few cases you can consider as a malignant paroxysmal positional vertigo. I'll come, okay? Now, straight talk, as already they have explained, posterior canal means torsional offbeating nystagmus. You have to mug up this or anything, science behind it. Science behind it. You have to read a lot of neuro-ophthalmology, how the eyes are connected to the vestibular system. Then you'll get to know that, okay, why it is happening in the posterior canal. Okay. But let me tell you, don't go behind the test you are doing. That's I've written here. Always check nystagmus pattern. If you will do Dixon-Hall-Pike, and if you are not getting a torsional component, then don't think that it's negative positive. No, don't think. It's horizontal component means think. It could be a horizontal canal. So even if you are doing Dixon-Hall-Pike, even if you are doing Maclear-Pagnini, any test you are doing, but if you are getting nystagmus, consider nystagmus for a diagnosis, not the particular test what you are performing. Clear? Now coming to why it is called magic. I have written a word, magic. Being an audiologist, when the patient is coming to you, they are so much frustrated by going different doctors, getting lot of medicines. And being a vascular practitioner, when you are getting the BPPV diagnosis and treating the patient in the same setting, patient will say, sir, you are God for me. I've seen patients are crying and telling that Google review that you are God. So, because audiologists have that much patience, we know from our speech therapy background, our BERA, when we are doing a lot of patients, we know. So, we are involved with the patients, trying to get the particular test and diagnosis we are doing. Many doctors are knowing it, but due to their busy schedules, they are not doing it. So, they have written BPPB, again medicines are there, right? Next, nystagmus characteristics already they have discussed. I will not go in so much details. So, these are the BPPV. Already diagnostics, tests, therapeutics, lot of maneuvers are there. Don't be so confused. Go simple maneuver, test whatever you are comfortable. Practice it. Unless until if you will not practice, you will not perform in front of the patient. You will be confused, okay, I will move to the right side or left side. Then patient will know, he is not. Okay, this is the typical PPV pattern. They have shown some videos, that's why I am not showing any video. This is the graph, okay. You will see as they said, crescendo decrescendo pattern, nothing, something different about it is just intensity increases, gradually it will deteriorate. So here you can see offbeating nystagmus, this is vertical component, and this is the horizontal component. So in this way, you can see the diagnosis and you can try to treat the patient. So I'll go atypical cases. Case number 1, a 31 years male complained of head drilling during sitting to supine, supine to sitting in the morning. History, no headache, no hearing loss, bilateral occasional tinnitus with ear blocking sensation, neck pain, burning sensation inside head, sleep disturbances, irritation to bright light and sound. Okay? Audiometry, normal, speech audiometry, normal, impedance, everything is normal, normal medullary function, BAMP is also not, frequency tuning not observed, it said normal presentations, and ECOG is also normal. So this is, they showed one video that is called VNG, and this video is called COG, cranio-oculography, little bit advanced version of VNG. You can see the nystagmus pattern. I have not written here Dixon-Hall-Pike or in maneuver. You tell me, what is the test? The head is moving, you can see, and tell me. No, come. Now see. Dixon-Hall-Pike only. we are doing little augmented Dixon Hall Pike. One test we can get at least a different kind of BPPV. I'll discuss on that. What kind of nystagmus? Left? All right. Left, okay. And torsional component is also there. So what is your first impression? Left side posterior canal, BPPV. Okay. Now for right. Don't see those nystagmus. That is the head movement time. Okay. Now see. Upbeating. Upbeating. Right beating. Upbeating. Or down beating. Upbeating. Okay. So when you try lot of maneuvers, earlier it was like people thought it's a left side BPPV. We did Apelles maneuver, nothing came out. Patient came on the 4th day, 5th day, 6th day, 1 month continuously. Patient is also fed up. You are also fed up. What to do with this? So my quote is that if there is no clue, then what to do? Go to your basics. History. History is telling irritation to bright light, irritation to some burning sensation, neck pain is a suggestive of vestibular migraine patient. And you are trying to treat with maneuvers. Not possible. So this is another information for the audiologist to know whom to send this patient. I will send this patient to ENT or I will send the patient to a neurologist. Why not ENT? ENTs are also capable writing those medicines. Nowadays, vestibular specialists, those who are done vestibular practice, they know what kind of medicine they are going to prescribe. But being an audiologist, my job is over. What to do next? Rehabilitation. Before that, you need to know, being an audiologist, what diet they should follow, what kind of lifestyle modification you are going to change, take a detailed history of that, because nobody is doing that. Nobody is doing. Doctors will write medicine only, go, take the medicine for 1 month, 2 months like that. So as a being an audiologist, you have to decide with the patient, change the lifestyle, change your diet plan, and do the rehab for another 15 days, 20 days, whatever. Or teach the patient how to perform this rehabilitation at home, they will do. Don't give that chart, Kauston Cook's exercise, they will not follow. Select which rehabilitation you are going to prescribe. Okay, patient base, you have to decide therapy. Next case, 49 years female, complain of head drilling during sleeping to right side, also turning head to right side. History, no headache, bilateral tinnitus with ear blocking sensation, hyperacusis, neck pain, vomiting with nausea, noise exposure, episodic multiple times a day, very brief in nature, sometimes symptoms less or no vertigo. Each episode lasts from seconds to minute. The first impression, BPPV, right? Okay, let's see. Audiometry, moderate SNHL, left minimal SHL, normal. Speech audiometry, you can say SRT 65 dB, RS very poor, 20%. And impedance, bilateral reflexes are absent. BEMP, absent in that side. ECOG, if you see the area is more than 5.29. I'll come. So first, next impression is from that. Hearing loss, ECOG also affected, BEMP affected, then it's a menial stages. Very good. Now see. Dixon Hall Pike negative, as you people are selling negative, so I'm using that word. Negative means no nystagmus. And macular pregnancy also, no nystagmus. Now I'm doing head hanging test, deep head hanging test. Now see. Downbeating? Yes or no? Downbeat, just see. Right? and downbeat. First you will see some downbeat, then it's right side. So what is your impression? Anterior canal BPPV? No? So if we'll do Meniere's treatment also, patient will not respond to Meniere's. Like no, like they are telling, no sir, this medicine not work out for me. For initial 5 days it's okay, then it's habituated with me, I don't know. That Abortin I have taken since 5 years, 6 years, like that. And you are getting an anterior canal BPV kind of pattern. You are thinking it's anterior canal BPV, treating with a Jacobino maneuver. Not possible with this. Then there is no clue. Then what to do? Okay, let's see. We'll go for the MRI. Earlier the patient also did a MRI, normal MRI, it came as a normal study. So the second time we did with a contrast MRI, MRI shows ICA loop on the right side, but normal brain study. What this? Normal brain study means whenever you are not, as being an audiologist, you are not sending, but doctors, when ENT doctors are sending for MRI, the technician who is doing MRI, they are thinking that it is a stroke patient. So they are just looking at the fourth ventricle or the stroke normal, because the technician is doing the recording. The evening that radiologist will come, do the reporting normal. Because they are thinking somebody is sent for MRI means it's stroke protocol. But being an audiologist, when you associate with ENT, tell them to write a fiesta sequence. But you'll get a fiesta sequence means being an ENT, we want CP angle, we want particular those areas. So when they will do contrast MRI, you will get a ICA loop, and that ICA loop is called? That ICA loop is called contralateral cross compression or vestibular paroxysmia, new term for audiologist. Okay? And it is looking like same as your vestibular schwannoma sometime. You will be confused. So it's retroclavicular pathology in my speech audiometry. I don't know, it's a Meniere's, it's a retroclavicular pathology. So confused about that. As MRI is not showing any kind of tumor, so don't be confused about that. It's a sometimes your vestibular paroxysmal patients come with a normal MRI also. So how will you diagnose the patient? Simple, there is a test called hyperventilation test. In BNC system is there. So tell the patient to hyperventilate for 90 times. Then what will happen? The alkylation of the oxygen is trying to give input to the auditory nerve, neurovestibular nerve, but due to blockage there at the junction, there is a ICA loop, you will get a nystagmus pattern. It's a biphasic, it's triphasic, different kind of nystagmus you will get. From that you will got an idea it's a case of vestibular paroxysmia, because this is a particular, there is a medicine called carbamazepine or oxmazepine. When the doctors will write that medicine, after 3 days the patient will say, thank you so much sir, my vertigo and everything is gone. Tinnitus is also gone. Okay? So sometimes you have to decide on the based on medicine, sometimes you have to decide based on your test, sometimes you have to decide based on your history, and sometimes with your trial and error things. Because we don't know. First time we saw it's a Meniere's disease, then we will saw it's a retroclavicular pathology, sometimes we say it's anterior canal BPPV. Then you can decide with a doctor, because it's not a one-day journey. Okay? And be assured that your doctor should be so cooperate to you, what you are telling, and you have that in-depth knowledge on that, and doctor will believe on you. They'll start writing that medicine, what you are recommending, what you are telling, and you will see the success. These are my stories. Okay. As I said, hyperventilation, biphasic nystagmus. This is ICA loop. Third case. We have time? Okay. 45 years male, audiometry C. Patient, some simple complaint, I had a sudden hearing loss. Okay? We did audiometry, speech audiometry completely affected on that side. I'll go a little faster. Now see. Here I am not doing any kind of, Dixon Hallpike or any maneuver. Just I am doing a sitting positional test. Okay? Yum test, pitch test, and roll test. Now just check. This is called high frequency head sec test. Yes, nystagmus is there? Could you appreciate? Yes. Now, you can see after hyperventilation there is a right first, you can see here. You can see here. Some right breathing components are there. After some time we will see. Hello, hello. So first, after head high frequency head check, you can see some right beating component. Okay? And then you will see some left beating component. I'll show you. So this is called biphasic pattern also. And this is another. See what I'm doing? Just checking the ear position. Because the patient demonstrated me. Sir, I have a sudden hearing loss. When I'm doing this, I'm getting vertigo. I can't even ride my bike. So according to that, I'm just changing the thought of my assessment. I did this kind of ear test. Now see the nystagmus. Very faint. When you do a jerk kind of things, or if you are doing any F-fit or V-it, you will get that kind of pattern. So what is this case? You can see after this head movement, there are left beating nystagmus. You can see there is a left beating nystagmus. Okay? So then I got confused. What is this case? I thought it's idiopathic sudden hearing loss, but when this hearing loss is moderate, and my VEMP came a beautiful normal in this case. So I thought it's a normal. Why it is normal? Then I did once again. It's absent. Because that first time my audiologist had done something, it's artifact. She put it as a normal, so I thought it's normal, because I have not seen that. When I did on my own, I saw it's absent in that side. Then we'll send patient for MRI. Now say huge tumor. Okay? It's also compressing the brainstem and the fourth ventricle also. So immediately we send the patient for operation. Now I think last week that patient has got operated, and we'll do rehabilitation after that. So my differential diagnosis, when you'll consider from BPPV or positional vertigo, think about all these things. First is vestibular migraine is very common. Nowadays all male females are affected with migraine. Why? Stress, hormonal imbalance in females. Third thing is only what I have observed, your lifestyle, diet, and mobile watching in night. Please believe me, those who have migraine headaches, stop mobile watching in night in sleeping position and call me. You will believe that it's a miracle for you. To next day morning onwards, that headache, that things will not be there. Okay, please stop that. Then vestibular migraine. Sometime patients will come to you. When you will do test, you will get a first upbeating nystagmus in some patient. Sometime you will get a downbeating nystagmus, and most of the time downbeating nystagmus female will get. And those who have episodic attacks in 2 to 3 times in a month, then it's called a nodular migraine. Cerebellum has some impact on them. And cervicogenic dizziness also sometimes confused. Vertebrovascular insufficiency or atherosclerotic vascularitis also giving an same BPPV kind of pattern. Vestibular paroxysm we discussed. Third window syndrome means dehiscence. Superior semicircular canal dehiscence, posterior canal, lateral canal, perilymphatic fistula, and enlarged vestibular aqueduct syndrome. All these things also may be possible in, and you look like a BPPV. CPPV, as I discussed, all these cases are called central except this third window syndrome. But when it is called MPPV, that means there is a stroke, pica stroke or ICA stroke, and also there is a huge tumor because it's malignant. Okay? And these are the different kind of cases you will see in your practice when you will do in day-to-day practice. So what are other guidance you have to learn or you have to give to the patients? Lifestyle change, diet modification, adequate sleep, no dehydration or no upper respiratory tract infection, adequate exercise, no sirsasana in yoga. Many people will do maneuvers, they will come with a sirsasana. Sir, again have this thing happened. Okay? They are telling I'm like fitness freak. What a fitness freak? Don't do that. Okay? Use proper dosage of multivitamin, vitamin B, C, D, what they are discussed. Lot of studies are there. People are not believing in a international forum also. No, there is no correlation between D and vitamin B12, but we have observed in our day-to-day practice. Another thing, in migraine patients, you will get a erythrocytic sedimentation rate is so high. You'll ask those patients, do you have any knee pain? Yes, they have knee pain. They have neck pain, body pain, everything. Then, if it is not successful, after doing all these things, if it is not successful, do a proper VRT with help of doctors, give proper medicine, do VRT, and if it's required, sometime in BPV patients, so you need surgery. But nobody is doing. One of doctors like Dr. M.B. Kirtan or somebody is doing. But still it's a debatable topic, is that they have removed all the autoconia from the semicircular canal or not. Future doubts. Why women more affected than men? Already discussed. Due to hormonal imbalance, lot of stress, they are taking a lot of responsibility at home. Why incidence prevalence of BPPV are underestimated? Why? So always we are not going in depth of knowledge. When you are doing into vestibular practice, please believe me, need 3D. Depth of knowledge, dedication, and daring to do. If you have a fear that, oh, no, I will do this test, patient will vomit, you can't do. So you have to have a dare in that. How anterior canal is possible? Many literatures, if you go to a UK, you will tell people anterior canal exists, they will not believe on you. US people believes, UK people, they don't believe. Those two schools of thought. How often downbeating nystagmus of peripheral origin due to involvement of anterior canal? So all downbeating nystagmus are not BPPV. If you are getting only downbeating nystagmus, there is no torsional component, please send the patient for MRI. Please tell the doctors, please sir, it's not my case, you go for MRI. And you will get a beautiful downbeating component. Why? Maybe sometimes it's a tumor, sometimes you will get a downbeating syndrome. Some cases are there. Why is the right posterior canal is BPPV more observed than the left? Is there any study? Yes, there is study due to your faulty sleeping habits. Okay? In India, we are telling the left side is good because heart is there, that upper respiratory tract infection will not happen, the acidity will not come. But in some time, that due to faulty habits or due to any kind of surgery, if they are sleeping to the right side or something like that, they are getting more. So study is saying right side posterior canal BPV is more. Why so far we not discussed here? That is, what is that? Any kind of posterior canal, always we talk simple, geotropic. It could be apogeotropic. So we have not discussed apogeotropic pattern of posterior canal. We have not discussed short arm canal, posterior canal BPP. They're just short arm, people see the anatomy, they're just short arm in the posterior canal. We have not discussed so far because BPP is not a 1 hour session. We should do a seminar on 1 day or 2 days like that. Okay? And light cupula. If you take alcohol, after 3-4 packs, people are telling I'm feeling giddy. So that's a light cupula syndrome. Huh? And new things we have invented, we are trying to portray this idea to Bharani society, pseudocupular syndrome. What is that? Sometimes you will feel like it's a BPPV, but after a maneuver, sometimes you will say, no, there is no nystagmus. Patient is telling it's subjective, but I am not getting any nystagmus. Maybe there is a canalith jam. There is a huge autoconia, like a stone kind of particle, with a mass or membrane around that, and it is stuck in between that canal. You will get like, it's another pseudocupular syndrome. You will feel like it's BPV, but it's no, nystagmus are very faint. Then, canalith jam, another concept in lateral canal BPPV. So, these kind of patients, when you will see, you will confuse. So, don't be so confused. Once you start day-to-day practice, what you'll do, you'll get confidence. You call someone, if you are like, you think that okay, this person has done a lot of work or something, call this person, they will give the idea. Do some kind of different exercise maneuver, because lot of maneuvers are there. It's not like 1 or 2 maneuvers. Once you'll do that kind of maneuver, like in Juma maneuver, sometimes we are doing Guffoni, Appiani, not successful, we are doing Juma maneuver. Sometimes people are doing barbecue roll maneuver. Okay, so a lot of maneuvers are there. Once you'll get into the vestibular science, start with the practice, you'll mastery of that. Okay. So, please don't hesitate to ask leading questions when dealing with RIGI patients. Observation is the very good. Always being an audiologist, observe, please, good observation, and we are mastery of that. If there is no clue, then what to do? I discussed. History. Okay? These are my acknowledgement. Ma'am is here. Due to Vanija ma'am only I am standing in front of people. And knowing is not enough, we must apply. Willing is not enough, we must do. Okay? People are telling vestibular science is a very difficult subject. No, it's not. Only you have to have interest or passion to do vestibular science. You'll enjoy like anything. You'll feel like I'm different from my colleagues. Doctors are start respecting me, and I'm doing different. Thank you so much.
Now my job is much easier. I am supposed to be summarizing all 3 of their presentation, so I hope I should be able to do it. I'm going to be like a teacher once again, which I do every day. So now let's revise and see how much all of you have got it. Okay, so I'll be asking a lot of questions and you are supposed to be answering it. Don't hesitate to stand or raise your hand. Okay, so now, till now we have learned that there are primarily three types of BPPVs. We have three canals, anterior, superior and, anterior, lateral and posterior. Posterior being the one of the most common canal. Okay, so I'll be showing you the different types of nystagmus and you are supposed to be telling me which type of nystagmus, which side and what may be the possible canal being affected. So we'll begin with the first video. Can I? Is there a nystagmus present? Yes. Which side it is? Is there a torsional component? No. So you know we are doing the roll maneuver. First we start with dick sulpike. For this case we started, there was no nystagmus on the dick sulpike or maybe minimal, so we started with the Pagini maneuver. We started with left, came to the neutral and now we are turning patient to the right side. So do you see any nystagmus on right? Yes? Okay. So what is your possible diagnosis? So after I am just showing you the nystagmus, that doesn't mean that you are looking at the nystagmus and diagnosing the patient. Here I am assuming that rest all history has been taken care of it and all the other possibilities have been removed. For example, the audiogram and all other possibilities that Swarup sir has just discussed. So this initial cases I am talking, ensuring that there are no other possible conditions and there is a nystagmus which was seen and there was a fatigability. So we diagnosed this case as having horizontal nystagmus, initially right beating and left beating. So what you need to ensure that it is geotrophic or apogeotrophic. So when do you call it as geotrophic? When you turn the client on the right side and you see the nystagmus beating towards the down, geotrophic, okay, on the right side. If you turn the client on the right side, but if you see the nystagmus beating on the away from gravity or on the left side, you call it as apogeotrophic. So we will see the treatment now. So normally there are many different types of maneuvers which have been mentioned. If you read, go on reading lot of articles, but to remember as an initial learner, I have put very basic maneuvers, but as you go inside it, you can start reading more and more. So if it is a horizontal nystagmus, the standard maneuver which is given is barbecue roll maneuver. Okay, so can I ask? So I'll just demonstrate how the barbecue roll maneuver is being done. Yeah, okay. So the first step for the barbecue roll maneuver is your the Pagini test, that is roll test. So take the patient downward, lift the head 30° upward, turn to the affected side. So suppose if it is right side horizontal canal, turn the head to the right side, hold it for 30 seconds. It's very important to hold it because you may not see the nystagmus soon after taking the position. So maybe after 15 seconds, 20 seconds. If patient reports dizziness or nystagmus, hold it till the patient says that nystagmus, till the patient reports that there is no more nystagmus or no more dizziness and nystagmus disappears. Then turn the patient to every 90°. So you are turning the patient on his shoulder with the head upward on the right side. Okay, again holding the patient in the same position for till you see there is no nystagmus for minimum 45 seconds. Okay, or at up to 1 minute. And after 1 minute, you are literally rolling the patient. That is why it is called as barbecue roll. So you are taking the patient on the stomach. So patient is facing towards the floor. Okay, again holding the client for in that position for 60 seconds. Okay, till the or even though patient may not report dizziness, but you have to hold it. And then after 60 seconds, coming back to the original position. So at least 4 times you are taking the client in different positions. So this is the simplest maneuver that you can remember for which type of BPPV? We are talking about which type of BPPV? Horizontal canal. Okay. So that is usually done if it is a geotrophic nystagmus that you see. If you see the apogeotrophic nystagmus, means you are turning the patient to right side, but the nystagmus is away from the moving. So we will do the Guffoni maneuver. Let him be in that same position. We'll do the Guffoni, yeah. That way also. So if for the Guffoni maneuver, you have to turn the patient's head again 45° to the affected side. So suppose you know that it is right beating, so turn the head towards the 45°, okay, and make him lie down quickly. The patient is looking downward towards the floor initially, and hold the condition for 45 seconds to 1 minute, and then turn the head towards upward. So you can tell the patient to look upward towards you or towards the ceiling, and hold the condition again for 45 seconds to 1 minute, and then take him in the sitting position. So there are many maneuvers. If you go on reading about the horizontal canal treatment, you will see 10 different maneuvers, but at least for the beginning purpose, you can remember that barbecue roll is used for the horizontal canal if it is geotrophic, and Guffoni is used when there is apogeotrophic. So now please check the nystagmus. You may have to wait. Stand there. So what is this? Is there a nystagmus present? Is it a nystagmus? Present or absent? Present. Upward, down beating? Okay. So what is it likely to be? Horizontal, posterior, anterior? Posterior, yes. Torsional component is not very well visualized, but yes, it is upbeating. And right side, left side? Right beating, okay. So what will be the diagnosis, provided I have excluded all the conditions? How do you exclude the other conditions? You have to remember that whether it is a vertigo client, you have to do your pure tone audiometry, you have to do your speech audiometry, you need to do your emittance audiometry. And when you know that if it is a typical BPPV case, you will see symmetrical loss or you might see normal hearing. Okay, WRS should not be significantly affected. Okay, and there should not be other history of tinnitus, blocking sensation, which you see in Meniere's disease, or there should not be history of severe vomiting, which or severe vertigo, which lasted for more than 24 hours or more than 10 hours, because BPPV is a condition which lasts for few seconds to minute. Okay, so the patient will come and say that I have a vertigo which lasts for 1 minute, 2 minutes, 5 minutes. Okay, if you have patient who says that no, it is like for more than half an hour, 2 hours, or it is there throughout the day, then it is not a BPPV. There is something more. There may be a BPPV, but there is something more than that. Okay, so I am ensuring, I am showing these videos saying that all other conditions have been ruled out. So this is a condition which shows that there is a posterior canal BPPV. So which maneuver is used? Everybody would have heard about Epley's maneuver. Everybody heard little bit about Epley's maneuver? So which is like one of the oldest method to treat the posterior canal BPPV, and very easy. And the success rate among all the different maneuvers which have been described for posterior canal, one of the most successful maneuver is Epley's maneuver. So they report around 88% of success rate or nearly 90% success rate with Epley's. You can also use Semont maneuver, but the success rate of Semont is relatively less. and which is more difficult also to perform. So I will explain you how the aplaze is done. So for doing the posterior canal treatment, you will start with the Dix-Hallpike. First step is Dix-Hallpike. Turn the client to the affected side and put him in the lying position in such a way that head is in the hanging position. This is your Dix-Hallpike, first step. Okay, and what the second step is, hold the position for at least 1 minute. You will see that there will be a nystagmus. You wait till the nystagmus disappears or the symptoms disappears. So sometimes you may have to hold it for more than 1 minute. The patient will suddenly feel very high vertigo, so he'll try to catch you or he will try to hold your arms, and he will also try to blink. He will not allow you to look, allow you to observe the nystagmus. That is but natural because he's feeling dizzy. And after holding it for a minute or more, you are turning the patient towards the opposite side, 90-degree opposite. Okay, so you started with right side, you turn to the left side, and you are again holding the position for 60 seconds minimum. Okay, and then it's very simple, that's it. And then tell the patient to get up slowly, putting the legs down first, and then with the clinician's help he can get up. In the same way, sideline position. So is it difficult? Only 3 steps are involved. Okay, and if you see, and immediately patient will say that I am feeling much lighter, the heaviness is gone, and I am feeling much better in terms of my balance. Earlier I was feeling imbalance, okay, while I was walking also. Not just positional vertigo, lot of time they say that I am feeling heaviness, I am having headache, and I am feeling imbalance while I am walking, even if there is only a BPPV. So you will see immediate improvement. Semont maneuver is done, it's little fastly done. So you make the patient in the sitting position, you turn the patient's head 45 degree towards the affected side, and make him in the supine, in the sitting position, but in the lying condition on that side. Hold the patient in that condition for 45 seconds to 1 minute. Come back to the sitting position and taking the patient downward very briskly, very fast on the opposite side. Again hold it for 1 minute. Okay. So like you would have seen lot of times that images, patient standing, going on the opposite side, then coming in the neutral position, coming again on the other side. So that is a Semont maneuver. You can do that also for the posterior canal. Lot of times they are also doing it for horizontal canal. But more successful is your aplaze maneuver. Then comes to the anterior canal BPPV. Anterior canal BPPV treating is very much similar to what you are doing for the assessment purpose. So you are making the patient lie down, head is extended from the table, examination table, and your head is in the deep hanging condition. You look for the nystagmus and lift the head upward and make sure that the chin is stuck or touching to the upper portion of your body, and hold each condition. You are holding it for at least 1 minute, and if you see the nystagmus is disappeared, then your maneuver has been successful. Lot of times there can be, you might need more than 1 attempt to treat the patient with BPPV. So there may be only 60% otoconia which has gone back to utricle, and then remaining still there is a dizziness. So you can again call the patient on the second day and you can treat it. So these are very simple cases that I have been described, but there are many patients who have multiple canals also. You see positive on aplaze, you see positives on the roll maneuver, and complex cases you might see nystagmus on all the this thing. So treating them is not easy. One by one you can start treating and you see how much improvement. Lot of times when you treat one canal, the otoconia goes into the other canal. That has been also noted. So it's really very difficult treating the mixed canal BPPV, but it is not very common, but though it is present. So another challenging thing that you have is secondary BPPV. I think I'm just going to summarize what he has said. So all of you are clear about types of BPPV. Primary BPPV or idiopathic BPPV, when there is no other associated condition and only positional vertigo. For some time you know now how to treat the patient by and large. But secondary BPPV is also very common. You will see that patient is having Meniere's disease, and then after few days of Meniere's disease, patient will say that I have positional vertigo. So don't ignore that he might have got the BPPV because of the Meniere's pathology. The otoconias have become loose and they have gone into the canal, and you can treat them with your maneuvers. Lot of times vestibular neuritis cases, after the inflammation of nerve, the otoconia becomes loose, and those patients with severe vomiting and continuous dizziness, that reduces, but after 2 weeks they will suddenly say that I have BP, I have positional vertigo, sudden in nature. So even they can have, you have to treat them for neuritis, the giving other generalized exercises, but you have to treat them for BPPV separately. And migraine patient, as he already said, you have to look at the history. When you look at the history, you will get to know that it looks like migraine. They will have continuous vertigo. When you do Dix-Sulpike or your roll maneuver or any other test, you will not see the fatigability. You will continuously seeing the nystagmus, which is going on for 60 seconds, and then you can diagnose them as migraine. Okay, lot of times this subjective BPPV and then subjective BPPV is because of the anxiety disorder and all those. Triple PD is also seen very commonly. Patient will say that I have positional vertigo. When you do Dix-Sulpike and all, there is no problem, and then lot of times they have anxiety disorders. So you have to take the case history really very seriously, and you have to take the decision accordingly. Cervical dizziness is again by exclusion. When you exclude all other pathologies and then you see the arthritis or spondylitis, then you can say that it is a cervical dizziness. It is done by exclusion. You exclude Meniere's disease, neuritis, BPPV and all other conditions. Paroxysmia, as he said, it is due to the vascular compression of the nerve, and it is normally you will see that patient will have tinnitus, hearing loss and vertigo. So whenever you have these three combinations, you have to suspect that there may be a central pathology, and you have to try and do all other central tests along with your regular tests. So, but patient will report positional vertigo. Paroxysm, same as he said, so you have to send these patients for neurological assessment. Vertebrobasilar insufficiency will typically show the sudden hearing loss, sudden hearing loss and with sudden vertigo. They may say that when I got up, I had I got dizziness, and you might feel that it may be a BPPV. But when you do all other audiovestibular tests and you realize that yes, they also have other associated issues like dizziness, ataxia, and other central vestibular involvement. So you have to ensure you can do some central pathology assessment like hint test and all, and you will see that head impulse is normal in them because it's a central pathology. A lot of times head impulse will be normal, and whenever the head impulse is normal but there is a dizziness and you see that there is a sudden violent dizziness, you have to suspect that there is a central component, and you have to ensure that you are referring them to the neurologist. Third window syndrome, as he already discussed. So this is a small table which I want everybody to just see. So you have BPP of 3 types, which is a idiopathic BPP, very easy to diagnose and treat. But BPP mimicking syndrome is your migraine. So a lot of times you have to rely on your case history, and there you will see non-fatigable nystagmus. Cervical dizziness, you will see that all other tests are normal. Vestibular paroxysmia, you will see that the patient will report that with hyperventilation test, he will have the nystagmus. And if there is a basilar insufficiency, VBI, you will see sudden Dix-Sulpike being negative, and you will see the patient is showing good improvement with the antithrombotic therapy, or you will see that central test being affected. Okay, so what I would like to end is you have to be very mindful. You cannot diagnose every patient with BPPV, having every patient with positional vertigo saying that it is BPPV. You have to use all your test battery, especially the first primary audiological test battery. Case history is very important. We have dizziness symptom profile. It is being very helpful. As soon as the patient is in waiting area, you can give that questionnaire. He'll fill up, and immediately you will get an idea whether it is, what may be the probable pathology. So that way you can save your time also. So yes, with practice you will become expert. It really takes time, but it is very gratifying, very satisfying, especially when you diagnose and treat the patient. And a lot of these patients goes undiagnosed and they are really suffering for more than 2 years. So it is our responsibility to get involved into the vestibular science. Thank you.
Thank you, ma'am. So as we bring this session to a close, I would like to extend our deepest gratitude to our speakers, Dr. Sharda, Swarup sir, for giving some real lifestyle advice as well. Vidhi ma'am and Sahil sir. We've covered a remarkable amount of ground today, from clinical breakthrough to practical applications. A huge thank you to our audience for your active participation, Mr. Saras for being an excellent subject repeatedly. Before we break, I'd like to request Vanaja ma'am to kindly come forward to present a small token of appreciation to our speakers. I request Vanaja ma'am to kindly come and felicitate Dr. Sharda. To Swaroop sir, a huge round of applause. Vidhi ma'am. Sahil sir. Thank you, ma'am. Thank you all. So it is, sure.
I would just take your 2 minutes. This was a really great moment for me because before 6 years in February 2020, I was as Saras. Okay, so I was attending a conference, ISAM 2020, and I was developing interest in vestibular, and I had attended Swaroop sir's lecture there. So after that lecture, I had decided that whatever I am going to do, I'll be in vestibular. And yes, today sharing a session with Swaroop sir is a great achievement for me. Thank you so much.
Thank you, Sahil sir, for that personal touch. It is now time for a short tea break, but before that, I request everybody to kindly assemble at the same place, that is the engineering college, for a group picture. We shall meet again in next 15 minutes for our next session, which is titled Beyond the Degree, Evolving Expertise in Complementary Areas of Learning. Thank you. So, in today's rapidly evolving professional world, growth extends far beyond classroom learning. It is about adaptability, interdisciplinary knowledge, and continuously reinventing ourselves as clinicians and professionals. This session aims to highlight exactly that journey. This session will be therefore moderated by Mr. Vivek Kumar and delivered by our esteemed speakers, Dr. Karnad Manke, Dr. Pushkar Deshpande, and Ms. Sareen Thomas. True innovation in healthcare comes from blending knowledge, compassion, and technology to improve lives. It is now my pleasure to introduce our next esteemed speaker, Mr. Vivek Kumar. Sir is currently serving as an assistant professor of speech language pathology at Sri Guru Ramdas University of Health Science, Amritsar, and is also the founder of the online rehabilitation platform, We Rehabilis. He has pursued advanced certification as a FEES specialist in cognitive behavioral therapy, oncology nutrition, and tobacco cessation counseling, showcasing his multidisciplinary approach towards patient care and rehabilitation. His area of interest include augmentative and alternative communication, dysphagia management, voice disorders, auditory verbal therapy, autism spectrum disorders, cochlear implants, and device development for speech language pathology. He has also contributed to research through publications in reputed journals, reflecting his dedication towards evidence based clinical practice and innovation in rehabilitation science. Not taking much time, please join me in giving a warm welcome to Mr. Vivek Kumar for his insightful session.
Hello. So, good afternoon, everyone. It's been a very long time when I graduated from here. And then one day I got a call from Pallavi ma'am, ki Vivek, you need to come here for this conference and you need to handle one of the panel where we are going to talk about how the things are going beyond the classroom teaching. Because during the whole journey, we are focusing on the classroom teaching, and after the classroom teaching, we are just going into the conventional pathway we follows. Like, there is a very interesting thing about our field, that the limitation is rarely the opportunity itself. It is often how we have conditioned to see it. Most of the people here sitting here, like, we entered in the speech and hearing sciences with a lot of hope and purpose. But during this journey, the path can be feel very narrowed when we are going to the further studies and almost the predefined. Since yesterday, when we are having a conversations, or we are interacting, or even I am interacting with the students, there is a very interesting discussion that came up to me. Like, most of the conversation is revolved around, after the BSLP or after the masters, what we are going to do. We are going to do in the academics, or we are going to do for the private practice. So we can see the mindset of the younger generation is only restricted towards the two things. Either they want to go into the academics, or either they want to go into the private practice or clinical setups. But I really want to tell you this thing, कि no, there are no predefined path, there are no restrictions for your thoughts, and why we are not, or why we are rarely talking about the other possibilities that we offers, or that our field offers to all of us. So during or having this thought, I'm going to start this panel, and I'm going to like to invite the speakers, Dr. Kanad, Dr. Pushkar, and Ms. Serene Thomas. So both, all three are going to join us during the panel discussion, and these all three alumni working, or they studied the BSLP from our institution, but right now, right now, they challenged the conventional path. They challenged that why we are going to do only the private practice, or why only we are going to be teacher. They challenged the basic thoughts, and then they carve their own path and going to on a whole different journey. So going forward, I would like to start with the first video by Dr. Kanat sir. So we can see how he started his journey, what he thinks, so that we can have a little bit of other perspective, or we can see how the things are go beyond that.
Hi, everyone. Thanks a lot for this kind invitation to speak at the alumni conference. This is my second time speaking at this event virtually, and I do hope to make it to at least one such alumni conference in person in the future, because it looks like a fun couple of days of events to hang out with your batchmates, friends, and everyone from college. So it's the topic that I was given is quite vague, and I personally had a very difficult time to actually think about what it is that the organizers want me to talk about. But they very kindly just sent me 4 or 5 questions to focus on, and so that's what I've done. So I've put the slides together addressing those 4 or 5 questions, and I'll sort of just walk you through those. So the first question that I was asked is, if this works, there we go, is how did I transition into neuroscience? So essentially, I started with BSLP and then moved into neuroscience research, what made me move from sort of clinical workflows or clinical work into brain sciences. And I've sort of previously spoken about this and also on a number of other occasions that I think it was the experience that I had in the clinics itself. So third and fourth year of my undergraduate degree was super fun because I was interacting with lots of different patients with aphasia, with Parkinson's disease, and various other neurological conditions at the hospital and elsewhere. And that really sort of influenced my thinking about the human nervous system. And that was sort of building on from my early interest in neuroanatomy and physiology. And in my second year, I obviously developed a very deep interest in electrophysiology as well, and thanks to Monaja ma'am's lectures largely. Because I still find it very fascinating that you can just put a bunch of electrodes on somebody's head and record millisecond activity from somebody's brainstem or deep cortical structures, and you present some sounds and you observe changes in the electrical activity. I think it's incredibly a fascinating area of work, and it still to date blows my mind. And so there was a lot of these sorts of combination of different things that motivated me in that direction. I realized that I wouldn't be able to combine all of these interests if I just stayed in the clinical track. And I was obviously interested in very basic questions in neuroscience as well, like how do we acquire language, how do we form memories, and that sort of thing. So research was seemed like then an obvious option where I would be able to combine all of these three things in practice in my sort of day-to-day job, as it were. Uh, so then the next question that I got was essentially that students who do BSLP often feel that the research is very abstract or it's very far removed from clinical work. And how would I sort of bridge that gap for them? So, as I said in the answer to my previous question, that I think clinical work will often give you lots of interesting questions, but it's for you to sort of take the first step and ask the next question and then read more about it. And that'll sort of start opening doors for you. But just to sort of contextualize how doing a PhD, which is sort of an essential degree, as it were, to if you want to pursue research as a career, then how a PhD sort of fits in the wider context of human knowledge. And I really like this particular blog post written by a computer scientist, I think. So he argues in this schematic that imagine that this is your entire sort of human knowledge, and by the time you sort of finish your elementary primary school, you know a little about a bunch of subjects. By the time you finish your secondary school or high school, you sort of have developed some more knowledge. You have some interest now at this point. At your bachelor's degree, you sort of build on top of that. So you have a broader base, and then maybe you have some specialization, as it would happen with BSLP as well, or any other similar degree for that matter. Master's degree, you sort of take a niche interest in one particular area, let's say electrophysiology, and then you sort of start reading more papers and broaden, sort of develop your really narrow niche and develop your expertise in that area. And reading papers, he argues, sort of takes you to the edge of the knowledge because that's where the sort of frontier for human knowledge is. And at that stage is when you sort of start doing your PhD somewhere here, right? And you focus, and you develop and sort of chisel away at that knowledge for many years, 4 or 5 years. And eventually that boundary sort of gives in. And that's what your PhD is like. That's what a PhD is looking like. But you are at this point, and to you, because your PhDs often can be sort of all consuming, you just feel like that's the entire world. But in the broader context of the human knowledge, PhD is just often a small blip and nothing more than that. But it's the training that you receive during your PhD that trains you to how to be a scientist. And that's the reason why you do a PhD. Uh, but going sort of beyond that schematic, I think it's important to remember that every diagnostic tool that you use or services or any electrophysiological test, even behavioral standardized tests for that matter, were once developed in some form of research lab. I'd also argue that not all research is academic, particularly in the sort of uh, uh, in present day, where lots of companies are also doing excellent research. Whether those are AI companies or if you're into sort of hearing research, then various cochlear implant companies do extraordinary research in developing those products. Whether it's the same applies for hearing aid manufacturers as well. And I always say this to a lot of people that it's like without research, you will not have new tools and products and services. So it might seem very abstract, particularly for a clinician, and if you're particularly very clinically oriented. But I think research has a very important role to play in a lot of the things that we do in clinics as well. Like a lot of imaging techniques were, for instance, developed once in a research lab. Uh, then the next question that I got is essentially what skills do you need to do a PhD? So I've worked with a lot of brain imaging tools. So if a student wants to do that, what what are the essential skills that one needs to be able to get to that level? And I always say this, and I sound like a broken record at this point, but patience, perseverance, and hard work. I think, irrespective of where you go, which PhD or which discipline you choose to do your PhD in, these things are essential things. The rest of the things come with practice, and that sort of forms the basis of your scientific training. Or if you do clinical doctorate, even you'll be learning specific skills along that way. But it all, so the bedrock for all of this is these things. But beyond that, if you are interested in sort of neurosciences, cognitive neurosciences, or any of the disciplines that I have worked in, then it really certainly helps to develop some strong skills in quantitative methods. So whether it's analyzing different data sets, whether it's statistics, knowing some sort of a computer language, or just knowing about basic maths, I think that goes really a long way. And again, it's not extraordinarily difficult. I think there are lots of resources available for free nowadays on the internet that you can brush upon those skills. And what I also recommend students do, if you are academically inclined, is that read broadly outside of your area, because that really opens up doors to new questions, new possibilities, and you start linking in different disciplines together in your head. And that's where really new breakthroughs happen. So I think if there's one takeaway from this, it is that you're going to need patience, perseverance, and hard work. But I highly recommend that if you are doing an undergraduate degree in audiology or speech language pathology, that you read something outside of those disciplines as well, whether it's in linguistics, psychology, neuroscience, engineering, product design, whatever it is. Uh, the next question I was asked is that you've received prestigious scholarships. What do you think actually makes a candidate stand out for funding? Now, this is really a very tricky topic. I don't think anyone's got very clear answers on what makes a candidate stand out, because an application for a PhD program and then subsequently for funding is a very complex process. And most big universities do take a lot of time in evaluating each candidates and their suitability for funding. So as I said, there is no one rule, but generally what tends to work is sort of the three P's of funding, which is person, project, and place. So you really have to justify why you're the right person, what makes you unique, or what skills do you have, what are the skills that you're bringing in to that specific department, then why that specific project at that specific department. So that sort of relates to the place as well. Why do you want to study at that university? I think those are the sort of things, and combinations of those make you stand out. But it really boils down to what are the unique things that you're bringing in that the other candidates are not. Because PhD, while it's called a studentship, you're often seen as a colleague at different departments where you sit on different committees. So they also want to see whether this candidate can be a good colleague to work with. In addition to these things, marks do matter to some extent, but not a lot. I think you just sort of have those minimum requirements for different programs. So as long as you meet those, it's fine. But the other critical important thing is how you perform at the PhD interview. And there might be one or two, sometimes three rounds of interviews that you have to go through. And those are the sort of make or break things in various applications. Then the last question that I have that I received was, looking back, was pursuing sort of a necessity for my career path so far, or could there have been alternatives? Now, the short answer to that is yes. PhD was absolutely essential for my career path. And I sort of see PhD is sort of like a license to practice, right? So you need, if you want to be a doctor or an audiologist, you have to have the relevant qualifications. So if you want to be a scientist, you have to have relevant qualification, and PhD is kind of mandatory. Whether you work in international universities in other countries or in India, I think even in India, UGC makes that mandatory now for any sort of career progression within that university. So that's quite important. And as I've argued at the start of my presentation as well, that I think it's the scientific way of thinking, and it's that training that you receive as part of PhD by doing, learning by doing, that's quite important. And I think without my PhD, I would not have reached where I am. So, for instance, I finished my PhD, without which I would not have received a postdoctoral position, without which I would not have received my current position as a statistician. So, those are all sort of linked things. Uh, in sort of non-academic research, if you are working in large companies, a lot of them for scientific research do now sort of make PhD as an important hiring criteria. So in some respects, it might be relevant. So if you're considering moving out of BASLP into sort of different areas, then PhD would be essential. Again, if you're doing so in sort of a research heavy environment. And as I've repeatedly said, that sort of scientific research teaches you how to think clearly. And that's a skill that can't be bought, and that you just have to learn it by doing. So I think with that, I'll stop. I'll and if you have any questions, just feel free to reach out to me or over email. Thank you.
Thank you so much, Dr. Kanad. Secondly, now I just want everyone see the Dr. Pushkar's video also. Then there is a very interesting fact I would like to share after that video. So can we play the Pushkar's video as well?
Hello, everyone. I'm Pushkar Deshpande, alumni of Bharati Vidyapeeth, SASLP. And I am quite happy to be here to tell you about what I've been doing after I've finished my university and what I've learned through. I also want to thank our college that they invited me. Hello, Arti ma'am. Hello, Sharda ma'am. Hello, Mansi, Siddhi, Rachel, and Mridul. They were my gang when I was doing my bachelor's, and also hello to all my classmates and my juniors and my seniors. I have had a great time during studying in Bharati Vidyapeeth, and it was only because of all of you guys. So today, I would like to just tell you some things that I've learned that you can apply or you can do after you finish your bachelor's or master's. So I'm going to quickly share my screen now. I guess you guys can see that if I'm not wrong. Great. Yes, you can. All right, perfect. So, a full disclaimer, right? I went the route of audiology after my bachelor's. So my talk will be more focused on audiology, but there are also parallels in speech. So you may have always had this question, at least I had it so many times. What can I actually do after my degree other than clinics, hospital, and private practice? What we're exposed to during our time in Bharti is clinic, hospital, private practice, etc. But there's actually so much more that you can do because imagine clinical work as a room in a big house. There is so many other rooms, and it's a very, very large house. You have academia, you have research, you have industry. Before we get into like the specifics of this, let me tell you what I've been doing in the past few years. So I did my bachelor's of audiology and speech language pathology, like you guys from the same place, and I had a great time. I learned a lot. I would actually like to thank our college because of the base that it helped me build theoretically and clinically. I think because of that, that's where I am today. And I, as a student, I always I never liked doing the theoretical parts of it, but as I've grown older, I've realized that the theory is the foundation of everything that you will do ahead in your career. During my bachelor's, I was like, how does a hearing aid work? How does a audiometer work? What could be different? What could be better? So that really interested me. So I went on to do a master's in biomedical engineering from the UK. It was a super cool program, and it taught me a bunch of things on how does an MRI machine work, or how does a stent in the heart work, or how do you design it, or what are the different considerations you need to take while working with such a device. And for my master's thesis there, I worked on developing this what do you call it? This calibration platform, and also a screener for people for low and middle income countries for hearing loss. I wanted to take it further, but I couldn't because of funding issues. And after that, I moved to India for a year, where for 6 months I just had fun, traveled around, spent a lot of time with my family, my friends, my grandparents. It was very, very nice. And while doing that, I started working in IIT Powai at an initiative called Jello, which was an application that used AAC for people with communication disorders. Well, while doing that, I also always wanted to do a PhD since I did my master's, and I was super inspired by the research environment. So I applied for a bunch of PhD programs. I got rejected from a few. I got into some of the interviews, but then I cracked this one, the PhD in audiology in University of Southern Denmark in Odense. So Odense is like this, I was third largest city in Denmark, but it's still only 2 lakh people, guys. So for us, I think a big and small city has very different meanings. For me too. Yeah, and I did my PhD for there for it took around 4 years to complete. And it was crazy with COVID and everything, but fingers crossed it was done. I completed it. Wasn't easy though. But yeah, so during my PhD, what I worked on basically was I looked at event-related potentials in response to tasks that demanded comprehension. And then I studied the effect of hearing loss and hearing aid use and cochlear implant use on these potentials. If you're interested, I ended up publishing 3 papers through my PhD. Please go and read them, and always reach out if you have any questions. After my PhD, I was like, man, I think I've studied for a long time. It's been tough. I wanted to do something different, so I became a product trainer for the European region in GN Hearing. And it was a really cool experience. So as a product trainer, I had to travel around and train people on GN hearing aids, make sure that help them set up their practices. So it was super cool it gave me a lot of like real life experience, how you talk to people, how you sell, because selling is a very important skill to succeed with many businesses. And yeah, while doing that, well, actually, I had a lot of fun because I traveled to 16 countries in 18 months. So it was amazing. And while doing that, I was also helping another colleague of mine with some research things. And that's how I got into my current role, which is a scientific advisor at a department called BrainWorks in GN. And what I do right now is research synthesis. I stay on top of all the research that comes out in our field of audiology, and then I explain it to people in different departments so they can take decisions in their work based on this research. So it's evidence-based. And I also help with running studies that look at the efficacy of our products using different techniques. And I mostly use EEG for validating how our GN hearing aids work. And I always like this line, right? The journey matters more than the destination. And like yours, mine is still going. So it's really exciting to see where life can take us if we just allow it to. Enough about me. So there's I'm going to talk about two main tracks today, the academic and the industrial. As the academic track is more hierarchical, that you do step one, step two, step three, it's like a ladder. While the industry, it's multiple branches that you can go into, that you can switch. So let's look at the academic track. It's, this one, many of us are there where we do a bachelor's and a master's, and it's very, very important to do this because that is your clinical and scientific foundation, especially if you do a master's thesis. We all started there, and some of you are starting there right now. If research is really interested in you, then you go in to do a PhD. It trains you to do critical thinking, research training, handling many tasks at the same time. And I always say this, right? We end up thinking that you do a PhD and now you're an expert in a particular topic. And I genuinely do not agree with that. I think you know a lot about one topic, but to become an expert, it's just that it takes a long time. Your PhD is just a training to put you on the journey to becoming an expert one day. Now, if you've done your PhD and you still like research, then you go for a postdoc. Well, you build your reputation, you publish a lot, you collaborate, you get new perspectives, you travel, because that experience is going to be very helpful when you start applying for assistant professorships. So you can go that route, the faculty route, so assistant professorship, associate professorship, and senior professorship. Or you could become a research scientist in a university, so where you don't teach, but you just do research. One thing that I felt that at one point, and I heard many people say, they always felt that their PhD was going to be like put guardrails on them, or it would be a prison. But guys, your PhD is your passport. It's not your prison. Once you do your PhD, of course you can work in academia, but you can also go into industry. And believe me, going from academia to industry is easy. People really want a critical thinker. People really want who can educate. People who really want who can do multiple things at the same time. But coming to academia from industry, now that is really tough. And I only know very few people who have actually done that. Cool. So now let's get into the industry roles of what an audiologist can do. So first of all, as an audiologist, please remember that it's not only hearing companies that you can work in. You can work in any kind of hearing tech, med tech, consumer electronics, anything that does with acoustics. There's so much that you can do. So the first one I would say is a clinical trainer. You travel around, you teach audiologists worldwide, and you are the bridge between the company and the client in terms of product. So you bridge product to clinical. You are the kind of the face of the company. It's a big responsibility because without you, they would not know how to use a particular device. And they will only sell more of your products if they're educated well on it. So you have to be a good educator and you have to be an expert in the company devices. Then advisory role like me, when you are, you know, in one of the hearing aid companies, someone with an audiology background is really look like sought out because well, you're the backbone, you are the expert in what the industry is about, right? So you can help with evidence generation, you can help with credibility, you can help shape the strategy. So you can advise on how do you think the field is going to evolve in the next 5 years or 10 years. So the company can make business decisions based on it. Another cool thing, I think, if you really like working with clinics, but you don't want to work in a clinic, audiology validation could be where you could go, wherein whenever a new product is launched, you have to test, hey, is this good? Can this live up to the claims that we're making? What is the SNR? How is the chip working? And audiology validation audiologist does this. So you test the products and you publish work based on that. You work with R&D, you work with psychoacoustics, but as a validation audiology engineer, you also teach people within the company on how to use or how to work with these products, or you can go and disseminate the knowledge that you have gained through these research protocols that you've done. Next, product manager. A product manager, well, it's your job as a product manager to manage which products go in, which products go out, answer any questions with the government authorities or the distributors, etc. So you build a roadmap, and it's super high responsibility because the trainer in a region, the salesperson in a region will actually speak to you about it, like, okay, hey, what can I sell? Cannot sell? Which devices can I train on? Next is also super important, regulatory and compliance. So regulatory is when you communicate and with the government bodies, because the hearing aid is actually a medical device, right? It's if I'm not wrong, it's a class 2, but not important. That's a tangent that I don't want to go on. So because it's a particular level of medical device, you have to have all documentation in place that it's safe for human use, safe for patient use, and these documents have to be maintained over and over again because you can be audited at any point. So this is what you work if you work in compliance, and it's a very stable and a very well-paid job, but in my opinion, it's a bit boring. But hey, I'm biased. But people who do it do really well in the industry, and they always have a job because it's very, I wouldn't say it's super tough, but I think it's super tedious. And it's if you have to be very good and organized to do it well. And next is homologation, when country by country you register the product with the government, because until and unless you get permission to launch that product in that country, you do not know, you cannot sell in that country. So homologation, regulatory, and product managers work very close with each other, while clinical trainers and product trainers work super close to each other. I may have missed a few, but so yeah, so please also pay attention in the other talks that you have. Perhaps they tell you something that I've missed. And you may ask, oh, there's so many options, there's so many things to do. How, as an audiologist, or even a speech language pathologist, how am I gonna do all that? Let me tell you, this degree that you're doing is absolutely amazing. That's because it's teaching you clinical reasoning. You know how to think in a complex environment. Your brain knows how to solve a puzzle to diagnose, or give like some very customized treatment to just a particular patient of yours to make sure that they do well, and then you know how to track progress. These skills are super important in any company. Scientific literacy, there is not a lot of people out there who know the research landscape well enough that they can actually advise on what's good research, what's bad research, what can be used as a claim, what can be used as a strategy. So this is a very valuable skill in the industry. Communication. Well, you communicate for a living, and communication is a skill that, if used properly, it can take you leaps and bounds. Because anything that we do, anything that we say, comes down to communication and cross-domain thinking. In a corporate, you will never just do your own job. You have to work in a team. You have to work with other people. And right now, you are actually being trained for it. Not in just terms of knowledge, but also how you collaborate with a lot of stakeholders, a lot of other professionals that you work with. So pediatricians, psychologists, occupational therapists, other speech therapists, right? And not only that, but you learn about anatomy, acoustics, neuroscience. You are already multi-domain, and you have the luxury to choose going ahead where you want to, which area you want to specialize in. So I think you are very, very, very well set up for a career in the industry, if any of you want. And you may ask, how do I go? Like, I really want to do it, but how do I go about it? I always say, do any of these 3 steps in any order, but do at least one. Always know the landscape. Which companies can you work for? For example, if it was hearing, you can work in GN, Auticon, Demand, Phonak, even Apple. Even Apple would, for their hearing program, would love an expert like you to advise them on what they can and cannot do, because they also are working in health. Then you should add a skill. And right now, I would say learn vibe coding, guys. But not just vibe coding, there's also other skills, right? Get into regulatory, take some courses on FDA or ISO, do a master's in a different field, or take an engineering model, learn coding, learn how to build a platform. Anything, trust me, any extra skill is never going to go to waste. Or learn marketing. You could work in the marketing department as an expert audiologist who gives advice on what you can say when you're launching a product. So there's so many things that you can do. And my third one is my favorite. Always speak to people, at least one person. Just go and talk to someone that you admire, someone that you think has done something cool, or just someone, because you will not believe how far you can get by just talking to someone and opening up a conversation. You do not need a perfect plan. You just need a first step, guys. That being said, I really believe that the world needs people who understand. The world needs people who know how to hear, who know how to communicate, and who know how to speak to one another beyond language. And because these sit at the heart of human connection. And that is why this degree gives you this unique perspective towards how people are, towards what you can do, and towards how the world works. So please use this skill as widely and as well as you can. If you have any questions, please reach out to me, and I would be more than happy to answer them. Thank you.
So, a big thanks to Dr. Pushkar and Dr. Kanad for sharing their valuable insights. I think both the journey remind us that there is no single fixed direction even after the BSLP. Rather than there are multiple possibilities shaped by the curiosity, exposure, and the willingness to explore. Uh, so basically, Pushkar sir is having a meeting, so we can have a couple of questions from the audience if they want to ask from both of the speakers.
Hi Kanath, hi Pushkar. I need to go to screen. Okay. Visible भी चाहिए क्या? Okay. Hi Kanath. Nice to see you after a long time. Okay, I have 2 questions. One is whenever we think of a PhD, the general perception is कि PhD and money cannot go hand in hand. A research person cannot have his financial goals fulfilled in a short term. So is this true? Is the perception still true? That is my first question. And secondly, there are a lot of master students who will be passing out or who just passed out, and they have their own financial goal in their life, and some of them also want to do PhD. So how should they go about it? Should they opt for their financial security first, or should they opt for their this aspiration of doing PhD? Thank you.
Pushkar, do you want to go first?
Sure. I think what I would say is the most important thing is go for a fully funded PhD. So actually, there are some countries, I think it's Australia, many in Europe, some PhDs in the States which fund your PhD fully, and that's if you do that, I would say yes, you can be stable while you do your PhD or you work on the side. That's what I did. But to answer your first question, can you fulfill your financial goals while doing a PhD? And I think you definitely can. Just depends on what you decide to do with your PhD after you've passed out. Yeah, Kanad, what do you say?
So it's an interesting question because there's this general perception that PhDs are often just a money drain, but I was also a fully funded PhD student. And you sort of know for the 4-year period that my earnings are not going to be astonishingly high. So you sort of accept that, but you're sort of using that time to really invest in your potential to earn in the future. And the only examples that I can sort of give are of my own mother. She also did a PhD in the 90s and had very little money, but that wasn't the important part. She was sort of investing in her own ability to do the work later. And similarly, in my case, the PhD years are hard, but once you sort of graduate, and depends on which pathway you end up taking, the returns that sort of it keeps giving you throughout your life are substantially higher. So you can still make pretty decent money once you graduate. So if you go to industry, for instance, in a lot of companies, the salaries for PhD graduates are astonishingly high, right? If you go into sort of startup route or start your own practice, those returns are pretty high. And even in academic domains, I think in different countries, academic jobs are by and large paid pretty well.
So apart from our speakers, I would like to also add one more thing to Sadanand's questions. So it's not about the abroad culture also, like in India. Like if you are investing right now for your time duration, like for example, I invested my last 4 years to find out to whom I do the research or I do the PhD or under whom I found so that I don't need to invest a lot of money and I can get funding also. So recently, past 4 months back, I was having a training under Professor Justin Rowe for the fees and the VFS. During that conversation, we had a talk like I want to pursue my PhD under him. And literally after that, even after the Indian universities also, there are ICMR projects also. Recently, the ICMR project released for the fundings of 2.5 to 3 crore rupees if you are pursuing your PhD in the rehabilitation domain also. So if you want to pursue these kinds of a career, you can go to the ICMR, you can go to the Rehabilitation Council of India, even the multiple universities apart from the who are working in the rehabilitation, they are also ready to fund these kinds of a student to pursue the higher education. So thank you so much to come up with the interesting question. If anyone is having any other questions. Okay. Thank you, Dr. Pushkar and Dr. Kanad, for sharing your all the insights or the information. So I think so we can move forward. And like when we are moving forward, so let's have a welcome to our other speaker who is here with us in person today. Uh, Before going forward, I think there is something like many of the students who are sitting here will connect with us. Like even after the BSLP, many students feel that they are very limited to a fixed clinical role. And how did you expand beyond that? I would like to ask Ms. Serene, like even when you completed your BSLP, you also somewhat thought you are fixed, ki either I have to go into the clinic or either I'll go into the academic. So how you not choose both the path and you found ki no, I'll pursue something new, I'll go into the hospital administration, I'll pursue anything else?
So I decided to pursue hospital administration during my internship. And so it started with the curiosity when we were posted in various hospitals. While we were in college, we were all, stuck into one clinical room. So when we went to the hospital, I started looking at various departments and I thought, okay, there's a world beyond the clinical room. So that curiosity led me to research into so then that curiosity led me to what other areas I can explore, and that's when I came across hospital administration. So to sum it up, BASLP has taught me clinical practice, and MHA gave me an insight into the system of patient care.
That is really a very interesting answer, especially the idea of stepping beyond what we assume is the only path after the BSLP or after the normal graduation. So like we all think we can go into the clinic, or we can open our own clinic, or we can go as a clinical supervisor or assistant professor. Ma'am chose a different path to go into the hospital administration and to work for that, and to can use her knowledge of BSLP and what she learned during the journey into the other domain as well. So I'll build my next question on all the three panelists. Like all the three panelists, they didn't follow the path the society framed for them. They questioned that path, ki why I choose only the clinics, why I only work in the clinics, or why I only go for this field. Basically, they all questioned those choices and they came up with their own answers. All three people having their own different journey. So based on that, I would like to ask Ms. Shireen, what are the some lesser known career paths within or around the audiology or speech language pathology that the students should explore?
As audiologists and speech language pathologists, I think we should not limit ourselves to just a clinical role. We are more like Wi-Fi, we connect everywhere. And is my time over? Okay. So it's like you can venture into healthcare management, into public health administration, opportunities in rehabilitation management, then telemedicine. I think the mic is also tired. Okay. Thank you. So there are various other other than healthcare management, there are other opportunities that you have if you think that you want to not stick to just a clinical role. Explore. There is ChatGPT, there is Google Gemini, everything on your phones available at your fingertips.
I think that is something many students are not even aware of, like where these discussions become so important. Even like what ma'am said, even yesterday when we had a discussion, or during that discussion, we came up that technology is sometimes cursed for us, but if we are using those technology, it become a boon for our field. For me, even I personally, like yesterday when I met Aarti ma'am asked me the first question on what new project, Vivek, you are working. So when I started my career in this field, during that I like to innovate. I like to think about why we are just thinking about the foreign devices or the foreign culture. During that time period, I started developing the own AAC systems. I developed the hand glove system. Recently, what ma'am asked, so ma'am, I like to tell you, or this is the first time I'm sharing, even just before I started to work on the virtual reality system. So in probably next 6 months, we are going to launch our own virtual reality in combination with the artificial intelligence for the speech language pathology audiological domain, where, so this is the path we never thought of. We always thought of we'll go into this field. But when I starting seeing the engineering people, they are working in the rehabilitation setup, but they have a very limited knowledge. We being a ASLP having an immense knowledge in our field, we want to see how the things are working. For example, if I like to give example, the audiology or the audiometer is working. But we know that which frequency we want, which mid frequency we want, or even the other frequency we want. But as an engineer, he developed a device grossly. So why can't we go and work with them and to develop the device, customizable device, where we can do the testings according to the need and according to our benefit? Then if you think about like that, the career options go beyond what you feel. Okay, I'll not take too much time and I would move forward to next question. Like, in your experience, what matter most? Like what matters most in a growth of a person? Do you feel it is a degree or it is a practical exposure?
So degrees are going to open the doors for you, but practical exposure will tell you what to do after you enter the room. Textbooks can teach you many things, but a textbook is not going to teach you how to convince a crying child to sit for 30 minutes and attend your session. So both are equally important.
Very, very interesting answer. Now, I'll move forward to the last question, and that is a bit of, I'll say that ki, when you started challenging the non-traditional pathway, or when you choose ki I'll go and pursue the hospital administration, what is your thought or what is the problem you faced? Because when we are continuing one pathway and seeing our seniors, our faculty working in the same field, and suddenly we are deciding, no, we don't want to pursue this thing, and we want to enter in something other or something related to that field, or even sometimes totally unrelated to that field. So what are the challenges you faced during, and what was your thought process at that time?
So the biggest challenge I faced when I decided to change my path was uncertainty. I was not sure whether I'm taking the right path, or should I follow my classmates, what my seniors have done, what my juniors are thinking, to pursue MASLP or maybe audiology or speech. I was not sure of that. But like I said, it was during the internship where I decided that no, I am going to go out of the box. And all thanks to one of my mentor, Rachna ma'am. She was the one who encouraged me to think beyond what I could do. So my advice to everyone would be, when you think of changing your path, invariably everyone around you would become your career counselor and tell you why management. Why do you want to go and do something different? It's up to you to decide whether you want to listen to them or you want to listen to yourself. And if you choose yourself, I think you will do best for your career, because it is not 1 or 2 years, it is the next 15 to 20 years of your life that you decide. Also, I would suggest that don't think that everyone had our career paths chalked at the age of 23 or 24. We have all learned throughout our journey. We are still learning. We are still exploring what else we can do. Thank you.
Thank you so much. So during this journey, I came up with a very interesting fact. Like the theme, like we are celebrating the 20 years, and the theme of our topic is the Beyond the Degree, where all the panelists, esteemed panelists, choose not the traditional path. 20 years back, when this institute set up, obviously setting up the institute is not a traditional path. At that time, maybe Aarti ma'am also thought, ki, no, I'll go do my own clinic. Other faculties also may thought, ki, no, I'll work the private practice. But at that time, ma'am had a mindset like, ki, no, I'll change that traditional path and I want to open the setup where the student can learn. And when she came up with that thought, so possibly, maybe I am right, I am wrong, but during that thought, when it came into ma'am's mind, obviously ma'am started working on that. Ma'am also faced a lot of problem during the initial days. All the faculty faced a lot of problem, but challenges will come, obviously. When you'll choose some other path, challenges will come. But if you are persistent to do what you want to do in your life, you are able to reach that position. It will take some time for sure. Sometimes you will fall down, people will let you down, people will say nothing will work. But if you are persistent towards the thing, obviously the day will come and everyone will come up and praise you and tell you, no, you achieved something. And right now we can see, like in India, there are a lot of college, BSLP college, and BVP is the topmost college of all the BSLP college. So that's what we achieved. It took 20 years for us. So we can also invest 10 years, 15 years of our life. So and now I like to summarize all the talks. Like there is no single correct path after the BSLP. What truly matters is stay open to the learning, developing practical exposures, being willing to explore opportunity beyond what we traditionally expect or ourselves. So I would like to conclude with the thought like the limitation is not the field itself, but sometimes how narrowly we define to our field. And the journey reminds us that ASLP is not following a single path. It is about having the courage to carve our own path and to become a ASLP who is all different to each other. At last, I would like to thank the organizing committee, all the faculty members, and thank you everyone for being such a wonderful audience. I hope everyone learned something and come up with something new. Thank you.
Would like to now call upon Dr. Aarti Vaknis ma'am to felicitate Mr. Vivek Kumar and Ms. Serene Thomas for today's session. Thank you, ma'am. We also have another felicitation to make. If you remember, the opening batsman for the conference is Rachna and her team here. Please come on stage, all of you. If you all remember, we had an inauguration right after their session, and they were very understanding to make sure that their session ended on time, and we couldn't felicitate them because of the inauguration. So we would really like to call upon Dr. C.S. Vanaja ma'am to felicitate all the speakers of the session, the moderator, Ms. Rachna Panikar, Mr. Naman Garg, Mr. Ramji Pathak, and Ms. Arina Varan Mathur. Can you please come on stage? Please come on stage, all of you. All of you, please. Vanaja ma'am is going to felicitate all of you. Light. And Anshul Agarwal is here as well. Can we have you on stage? Yes, thank you. Ramji Pathak. It's so nice to clap for your past students. And Arina. Arina Mathur. Can we have a group photo, please, with ma'am? Thank you. We will now be starting with oral paper presentations. These will be held in 7 halls. Sorry, I have another announcement to make. Is Madhuri here? Madhuri Bogade? Is she in this hall right now? Yes, Madhuri, please come on stage. I think she was busy volunteering somewhere yesterday and we couldn't felicitate her as well. Dr. Aarti Vaknis, ma'am, please can you come on stage? Dr. Kanad, thank you so much for joining us today for whatever little time we could have you, and we look forward to more such talks from you. Thank you so much.
Afternoon session of the conference of the second day. First, we'd like to begin with a talk, a clinical symposium by Mr. Sushil Sate. He's a company representative from Advanced Bionics.
Hi, good afternoon, everyone. Sorry for the initial glitch. Just wanted to introduce myself. Hi, I'm Sushil from Advanced Bionics. So I'll be just briefing you about Advanced Bionics product portfolio and what we have to offer. So this is just a brief video of Advanced Bionics
Since
manufacturing facility.
1993, Advanced Bionics has been helping people hear again, or for the first time. Together with Phonak, we are a part of the world's largest and most innovative provider of hearing solutions. Our engineers and scientists continue to be celebrated for creating many firsts in cochlear implant technology. First CI sound processor, designed for children. First CI sound processors that connect to virtually any Bluetooth device. First complete real-time remote programming. First CI system with linked bilateral, bimodal, and cross configurations. And also, over 150,000 ears implanted in over 130 countries. More than 500 patents, and over 100 partnerships with universities and clinics around the world. With a solid track record in cochlear implant innovation, we will continue to shape the future of hearing care. Together with our hearing care partners in over 50 countries, we've been trusted to provide life-changing results. And that's only because our mission has always been to put your patients first. Advanced Bionics, welcome to the world of powerful connections.
Yeah, so that was just brief about what Advanced Bionics is about. So what Advanced Bionics is currently offering to their recipients is we are into this field and we have a Phonak synergy, and we provide the impactful performance and empowering the access to the recipients. So Advanced Bionics has a global headquarters based in Valencia, California since 1993, and we were being a part of Sonova Group since 2009. So across Sonova, there are three segments under which Sonova is currently working. So consumer hearing, then hearing instruments, and the cochlear implants. So as you all know that in hearing instruments, Phonak is the hearing aid manufacturing company, and in cochlear implants, Advanced Bionics is the major part of Sonova Group. So over a period of till last 35 years, we have been implanted around 150,000 people with AB across the globe. This is just a glimpse of history of innovations which Advanced Bionics has done since 2009 when we got collaboration with Phonak. So there is an increasing cadence of product launches because there is a lot of technology Phonak which has been launching in in hearing aids. So in 2018, that was the landmark moment for Advanced Bionics, where we have launched the 3 Tesla MRI compatible implant, that is a Hi-Res Ultra 3D. And in 2019, we have launched AIM, that is active insertion monitoring. So what is that? I'll be discussing briefly in next slides. And the latest speech processor which we have is a Marvel CI, that is again based on the Marvel platform of Phonak. Now I here just wanted to say that there is a lot of buzz currently happening around that future-proof implant as the need of the hour. But I would like to I'm glad that every company is now moving towards that goal of having a future-proof implant. But since last 25 years, Advanced Bionics delivering these firmware upgrades. So you can just see that there are a lot of firmware upgrades which has been already being provided by Advanced Bionics for their recipients who are using cochlear implants since last 25 years. Coming to what product portfolio which we have is in terms of internal device, we have two types of implants, Hi-Res Ultra and Ultra 3D. In terms of sound processor, we have Marvel speech processor. And in accessories, there are some accessories like Roger, which can be used with our speech processor. Then cross hearing aid, which also can be used with our even basic speech processor. What exactly Hi-Res Ultra 3D, the implant which we are giving, provides to the recipients? So it provides better hearing performance with independent current sources, access to, just a second, access to the pain-free MRI. So you don't need to have any, patient won't experience any pain. There will be a hassle-free MRI procedure, and lowest number of device removals as per the international CI reporting standard. So that is the advantage of Hi-Res Ultra 3D implant. Now what makes Ultra 3D implant unique as compared to any other implant is that it has a magnet which is a 3D magnet, which is a multi-magnet assembly, which is available with our implant. So if you see in the screen, there is a carbon frame, and inside that carbon frame, just a second if I use a pointer. So you can see that this is the carbon frame, and inside this carbon frame there are these 4 magnetic rods. So whenever a patient goes into an MRI field, what happens is that these magnets get aligned to the different axis of the MRI field. So because of which there is no pulling of the magnet at all. So if there is no pulling of the magnet, then patient won't experience any pain. So just wanted to show you how it exactly works. Sound again left. Who's there? There's no voice.
Your patients require no preparation, no surgery, and no head bandaging. And if diagnostic investigations require it, magnet removal is easy. This implant does not require any restrictions on head orientation or head movement in an MRI field. The unique magnet assembly is composed of 4 rotatable magnet rods encased in a revolving disc. This design provides magnetic field alignment in all 3 dimensions, ensuring low torque and a pain-free MRI experience for your patients. Hi-Res Ultra 3D provides uninterrupted hearing to make life easier for you, and especially for your patients. When the scan is done, all they have to do is put their processor back on to return to hearing. Hi-Res Ultra 3D cochlear implant is hassle-free implant compatible with 3 Tesla MRI, another powerful innovation from Advanced Bionics.
So as you could see that this is the latest, this is the design which we have made, and for this design of the magnet, Advanced Bionics has received a MedTech award also in 2019. So that's the unique design of this magnet makes it compatible with either 1.5 Tesla or a 3 Tesla MRI. So patient doesn't need to worry for any pain or any hassles, because he will be able to do the MRI just like a normal person. He just need to take out this processor and go for an MRI. So that's how it makes the MRI procedure very simple. Now coming to so this already has been explained in the video. So there is no head restrictions and no head bandaging is required to done for the MRI procedure. So we always believe that the impactful performance always starts with the internal device which is being given to the patient. So always Advanced Bionics believe to give the latest implant which is available in the industry. I'll just take 2 minutes more. So we have two types of electrode choices. So we have a high-res ultra slim J implant. So that is a lateral wall electrode, and there is another high focus mid scala electrode. That is a electrode which is placed in the middle of the scala tympani, and both the electrodes helps in terms of preservation of residual hearing if any patient has. Then another thing is that most of the people were aware about it, that AIM is the tablet which has been launched from Advanced Bionics, which helps in terms of active insertion monitoring. So whenever you are inserting an electrode inside the cochlea, so we can monitor while doing the insertion, so that if the patient has some residual hearing, we can preserve that. And how we can preserve that is, it gives a real-time monitoring of the cochlea during the electrode array insertion, and you can do the objective audiometry on the OT table itself with the help of AIM tablet, and also you can do the NRI measurement and the impedances by using this AIM tablet. Talking about our external speech processor, we are the only company which has a dedicated pediatric speech processor, which is called as a Sky CIM. So it is dedicatedly prepared for the pediatric patients. So in terms of performance, we have a technology which is known as AutoSense OS. So it has a artificial intelligence where every 0.4 second, the machine analyzes in which environment the recipient is present, and all the background noises or background environment noises which are there, according to that it will activate or deactivate the features to provide the best hearing possible in that situation. And with this processor we can perform more than 200 automatic settings by using this speech processor. The another advantage of Advanced Bionics is that as we are a sister concerns of Phonak, we have a truly bimodal solution which provides a bimodal usage. If some patients has a residual has a benefit with the hearing aid on the other side, then it provides a truly compatible hearing aid with it, which works with your implant, so that patient have a more usability of the hearing aid on the non-implanted side as well. Talking more about Marvel, we have a universal Bluetooth connectivity. What I mean by universal is that any Bluetooth device in the world can be directly connected to our speech processor. So there is no restriction that there is a specific Bluetooth which only can be connected to our speech processor. So considering people are using laptops, tablets and everything can be directly connected to our speech processor. That is the unique advantage of Marvel speech processor. Talking about another advantage, or you can say that most of the patients travel across the cities for your mapping session, and they have to go to audiologist by traveling at least 2 hours or 3 hours. So for that we have offered a solution which is called as a remote programming. So exactly what mapping session patient is going to do by visiting the clinic, entire mapping session can be done remotely as well. Patient doesn't need to travel to the clinic, only they need to have a smartphone with the internet connection, and they need to download this app. So entire mapping session a clinician which is going to do in the clinic, same can be done remotely by remotely. Patient doesn't need to go to the center. Then another unique feature or app which has been launched by Advanced Bionics is last 2 slides only. That is AB Listen Fit app. So this is the first time in the cochlear implant industry that we have launched a self-evaluating app, because most of the patients ask that how do I know that my hearing is growing or not. So this is an app which has been launched by the Advanced Bionics, which can be used with the Marvel speech processor. So there are few tests which patient can perform himself, and he can send the reports to the audiologist and ENT surgeon, and accordingly they can do the adjustments if there are any adjustments required to be done. And that's how he will know that how his hearing is progressing with the cochlear implant. And this is the more digital resources which are available with Advanced Bionics. We have clubbed under one umbrella of Advanced DigiCare. So these are categorized into 3 categories based on pre-candidacy, candidate evaluation and post-implantation. So these are all online resources which all of you can use it and take benefit of it. So these are available online on our websites. And that's all from the company side. Yeah, thank you.
For the session. I would like to say that as audiologists and speech therapists, um, I feel like there's more emphasis on assessment and intervention for pediatric population, but there's not much that we're doing holistically for the geriatric population, what we need to bear in mind is that in geriatrics or in older aged people, in adults, we need to not just focus on just giving a hearing aid, or probably just looking at if they only are not speaking well, or if they have slurred speech, or if they have issues in terms of communication. But there's a drastic need for focusing on an approach where we not just tackle communication, but also swallowing, cognition, audiovestibular difficulties. So bearing this in mind, we'll move on to the next topic of the afternoon session, which is, can we have the slides, please? Sorry, should I? No, I'll continue, no problem. Okay, so bearing this in mind, we'll move on to the next moderated session for the afternoon, which is reframing adult and geriatric care, integrated care for audiovestibular, cognition, communication, and swallowing disorders. The session will be moderated by Mr. Nihar Pradhan. Mr. Nihar Pradhan, just a moment. Yeah. Mr. Nihar Pradhan is an alumni of our institution, who is a consultant working as a consultant ASLP, and for the longest duration he worked at Starkey Labs, Manke Hearing Clinic, among other places, and he trains audiologists on counseling, programming, and troubleshooting of hearing aids, and has conducted various presentations on community-based hearing health care at national and international programs. So with a huge round of applause, I'd like to invite on stage Mr. Nihar Pradhan.
Good afternoon, everyone. So I think you all are not feeling sleepy right now. I know it's after the launch. So let me introduce, we have 4 speakers: Shamangi Nakhre, Ashral Surana, Snehal Puralkar, and Kiran Godra. Please come to the stage. So you are going to have a very interesting session. The speakers have got real practical insights. So please don't try to sleep. Yes, so moving on to the presentation. Yeah. So I'll welcome Ms. Samangi Nakhre, who is going to say about the audiovestibular part of adult to geriatric care.
Hello, am I audible? Let me check your hearing. Am I audible? Can I request everyone to stand? Please keep your bags aside to avoid risk fall. I want everyone to stand up, please. Let me see how your cognition, your association, and your hearing is working right now. In meantime, they are trying to fix my technical glitch. We'll try to have some practical this thing. All the phones aside, can everyone touch their head? Shoulder, knees, toes. Can everyone raise their right hand, left hand, together, and clap? Very good. Did anyone fall? Oh, we have Swaroop sir. I would have got him, you got your assist from him. Is the technical issue solved? So in meantime, till this thing is getting fixed, is everyone awake now? Hello, hello. How many masters and bachelor students in the back? Please raise your hand. I'll be asking questions, and I've been asked that you will be getting IA based on that, and how you will be soon implementing that in your private practice. Please make sure you're paying attention, because we are standing just after your lunch. So masters, audiology masters, I'm more concerned with them. Where are you guys? Nahi hai? Speech wale? koi baat nahi, but how you will be integrating this into your practice later on, whether you choose. Okay, whether you choose, I lost my voice. So this is something new for me also. I took up geriatric care when I was in my stint in Cochlear a few years back, and then I moved to private practice. I would like to thank the management team for giving me this opportunity. Many a times I'm more into implants and implantable devices and diagnostics, where I don't get much time to focus about how I can do. A month and a half, Rucha called me up and said, Shamangi, this is going to be your topic of presentation. I said, Rucha, change kar de, aur kuch alag de de. So she said, no, you have to present on this, you have done this, aisa hua. I took it up. Since the time, I have seen a significant amount of change in the revenue of my clinic because I started implementing this together. So please keep your ears open, because I'm not going to much focus upon tests and all. The vestibular team in the morning session has done a fantastic job on it. But I'm going to talk what and where we are lacking and why it is a need of an hour. How many people are above 35, 40 here? Please raise your hand. First batch of millennials. I have a news for you also in my research, so we will be having a little interactive session on it. So as I'm little bit talking about reframing adult and geriatric care and integrated care, I'll be focusing a little bit on audiovestibular disorders and how we are managing it. If we see, when patients who come to us who are above the age of 50 are now to be considered an early phase of geriatric population. That is how the WHO has reframed their classification. We see them having communication disorder, communication issues, cognition issues. They are at a fall risk, as well as are dependent. We lose their independence. Mental health issues and the quality of life of them is quite compromised. And we are slowly moving from diagnosing to comprehensive care and how it can be helpful. And as an audiologist, we are just no more about testing, diagnosis, and fitting devices. Okay. About 63 million people in India have issues with hearing. That is 6.3% of Indian population. In next 4 years, our first set of millennials sitting here will be touching 50s or 45s, will be the first batch of our hearing screening. That's the reason I asked you who are the millennials sitting here. Okay, millennials are also further classified. Gen Zs, you can rest, but you can watch us and learn. Okay. Look at the prevalence of hearing loss: 1 in 200 infants, 1 in 5 teens, 1 in 5 adults, and 1 in 3 senior citizens. Our grandparents who are with us right now are one amongst the patients whom we are seeing day in and day out, and we are actually overlooking them. Why does this topic matter right now? It is no more about aging, it is more about healthy aging. Things have moved from aging to healthy aging. The elderly population is also increasing day in, day out. Because of the environmental factors, post-COVID things have changed, and there have also been reported a lot of hearing and balance disorders and major contribute to the disability, which also lead to reduction in the confidence and leading them to be dependent on a caretaker or their kids. If hearing loss is untreated, it also affects your communication, cognition, and emotional well-being. I have my colleagues who will be talking more about communication and cognition and how it will help. In vestibular dysfunction, significantly it increases the fall risk. If we see the main domains, what happens in elderlies, we see there is a reduced audibility, speech perception deficits, deficits in attention and allocation, tinnitus, and cognitive decline. And something very important, social isolation and emotional factors have been compromised. The reason I asked you all to stand, sit, you know what did I check? Can someone reply? Second, comprehension, hearing, and correct. So just to get it checked and keep you awake during my session, I had tried that. Good that I could screen it throughout. So in integrated audiovestibular care, it is no more between the ENT, audiologist, and sometimes speech language pathologist. It is more right now, it comes from ENT, physicians, it is also your nursing staff, your physiotherapists. Physiotherapists are going to be your best friends growing up in the fraternity, guys, and the rehabilitation centers. Pune has been doing a fantastic job about rehabilitation centers like Athashri, and I guess there is one apricot by Deepali. She's also doing really great job. You should reach out to her how she's managing it. And unfortunately, Mumbai has it, but because of the cost factor, we are much affected with it. And we are trying to focus on the independency of the patient and improving the quality of life. Not many patients are now living in a joint family. There is more of a nuclear family concept, which is causing an impact on overall rehabilitation of this population. When I talk about hearing loss, it is a multifaceted condition. When extremely sorry, this biophysiosocial model talks about particular things. While we clinically focus only on the audiogram and hearing thresholds, hearing loss in older adults is actually a multi-conditional situation. It impacts the cognition, emotional well-being, participation, mobility, independence, and overall quality of life. At the center of this model, we'll see this lady who's having a hearing loss and the following factors which are getting affected with her. When I look at it, biologically, aging causes cochlear hair cell degeneration and neural loss. This is very common, which we see in day-to-day living, and further leading to any maybe vestibular changes which reduce hearing sensitivity and balance function, which impacts the confidence of the patient. Major complaint a patient walks in the clinic, मैम सुनाई नहीं देता है, रास्ते में चलने के लिए डर लगता है, पीछे से गाड़ी आ गई तो, and भीति वाटते. These are the common layman terms a patient walks in the clinic and asks you about. From the auditory perspective, patients commonly struggle with speech understanding and noise, temporal processing, tinnitus, and auditory processing difficulties. Many elder adults tell us, I can hear, but I cannot understand. बायको बोलत असते, पण काय बोलते काय माहित नाही. What is getting affected? Central? Yes. So looking at all these factors, there is a cognitive domain which I have my colleague speaking about it, and the further important thing is your psychological domain, where you see a lot of anxiety, depression, stress. There are many patients who will come back to your clinic just to the fact that they want to come and talk to you with, when you have fit them with a hearing aid or you have done diagnosis, what should I do ahead? What is happening? And those are the patients who will also lack confidence in communicating or doing their own job and would be dependent either on their in-law, like daughter-in-law, or the caregiver. Recent advances in audiology are talking how can we cope up with this. We have AI driven hearing aids. Many patients, if they cannot commute, we have remote care, which we just saw in Sushil's presentation. We have teleaudiology, which helps us to connect with the patients and follow up. Speech and noise testing, please guys, we have MRAMs and people from Maharashtra can please use it as a very nice test and which can be implemented in day-to-day screening and diagnostic protocols. Cochlear implantation in elderly population, many a times we are just restricted to hearing test, impedance, and hearing aid fitting. We are losing out on 60-60 protocol and speech audiometry while doing testings, and we lose out those patients for cochlear implantation. Those patients are not happy, those patients are not doing well with hearing aids. They are covered under insurance, but we still don't have knowledge about it, and we keep them on hearing aids, and then we see that there is a slowly degeneration in those patients, and they are unhappy. They keep changing from hearing aids to hearing aids, but nothing working on it. Recent advances in vestibular care, we have many options. In Pune, I'm not quite aware about, but in Mumbai, there are 3 hospitals who have vestibular care under one care. Sorry, BVP is doing, I'm really sorry, BVP has that. In Mumbai, we have 3 hospitals which have audiovestibular care under one roof, where once the patient walks in, just like how you do a routine blood check, they undergo from hearing test till your vestibular thing, and it is a package and it can be done. But it comes with a cost, distance, and needs a person who has to be taken care with. So I'm not going more in detail. I have actually taken off my slides. Morning batch has done a very good job on describing how they have worked about it. More about it right now when we focus. The old model has been diagnose and fit device. We are reframing it. The new model talks about improving communication balance and participation and independence. So it is more about bringing the functional outcomes. It is no more diagnosing a patient and audiogram. It has to be integrated together. The corporate hospitals have been taking a very good care about it, where there are robotics, where there are vestibular labs, where there are audiology and speech language pathology under one roof, and doing it. Private practitioners, it's high time you see it. There is 63% of drop in Maharashtra in small and private practitioners, because of which corporates are taking up. If we can implement some of these in our own private practice and do it, I know it comes with a cost of investment, but it can be a good revenue generation for you all also, and retaining patient at your clinic. Major challenges which we see in audiovestibular care is late diagnosis. When we talk about pediatrics, we are still struggling at 136, where people are talking about 123. In elderlies, there is a denial, there is no acceptance. Late diagnosis, they don't come to us. How can we take care of it? Maybe implement them in the packages, how corporate hospitals have done, and work together. Social stigma, denial. Financial burden, definitely we have also invested in the device when we are investigating the patient. The patient also has to pay, and what pricing we are having it, and that is the reason many of the times elderly population are dependent on their younger population, so they drop out of doing such tests. Lack of insurance coverage, definitely few of them are covering the testings now, but few of them are not covering. Limited rehabilitation access, I agree to it. For every 5 lakh audiologists, 5 lakh population, there is one audiologist in India. This is a role of questionnaires. I have been implementing them very rapidly in my clinic. From the time patient comes in and is sitting in the waiting area, sometimes I'm busy, testing, or I'm doing better upstairs. But my receptionist knows that, okay, which language do you speak, sir? Oh, you speak this. We have this particular questions. Can you please help us fill it for us? Before the patient comes in and see the patient, I have an entire profile ready, what is happening with the patient with HHIE, DHI, and THI. Even if it is not that the patient is not having a complaint of tinnitus, I know that, okay, that is not my concern, I'm not going to touch about it. But before the patient walks in and sees you, you are having a fair amount of profile of a patient, and then you can implement. These are very much done by our own people from AYJ and BVP also, so which you can implement, and they are just 10, 20 questions which can be done by a patient within 10 minutes. From today's practice to tomorrow's impact, future direction, I would like to talk about preventive audiology. It is no more about diagnostic audiology, it is more about preventive audiology. We should move our shift from just diagnosis and also community healthcare and integrating it with our fellow professionals. Many a times you get these geriatric patients from your physiotherapist, so that's the reason I mentioned physiotherapists are going to be your new best friends going on in near future. Digital rehabilitation, insurance inclusion. How many of you know that PT impedance, if recommended by a doctor, can be included into insurance? Raise your hands. Out of 180, I can see only 6 people. So many times people come and ask me, Shimangi, OPD ka and for private clinics, how can they inculcate and cover it under insurance? If you have a proper documentation and letter of recommendation from the ENT or the physician whom they are seeing, and you give a proper report adhering the insurance bracket, they can cover it under insurance. Around 6,000 they can cover it under it. I'm leaving you with 2 questions. Nihar is here, he's telling me to wrap up. So, master students, I'm leaving you with 2 questions. As audiologists, are we still limiting ourselves to fitting devices, or are we ready to build integrated audiovestibular rehabilitation centers, which focuses a lot on cognition imbalance and everything? And the second question, with India's rapidly growing geriatric population, can adult and geriatric audiovestibular care evolve from service best practice into a comprehensive preventive healthcare and rehabilitation ecosystem? It's not for me, it's for you. We have come here after 8 years of experience, everyone is here, but you're about to get out and have an option where you can venture. We saw Kanad and we saw Pushkar doing different things. This is another opportunity for you to learn. Thank you so much.
Good afternoon, everyone. As we have decided, all of us are winding up our presentation in 5 to 7 minutes. Now, I will just quickly go. So, I will be talking more about reframing geriatric care in terms of cognitive perspective. So, usually when we see these cases, We always try to bifurcate audio vestibular, swallowing, cognition, communication, but in clinical setups they don't come in different isolated settings. They come together. So let's see what is healthy versus pathological aging. Healthy aging, slowest processing, mild working memory decline, but the independence is still preserved. Versus in pathological aging, rapid decline we see, functional impairment and loss of independence. If we are looking at epidemiology, around 15 to 20% of adults shows mild cognitive impairment, and dementia rates is globally increasing. Now different cognitive domains have different types of memories. Every memory impacts us in different types of activities. So working memory will have an early decline, which helps us understanding conversation and communication. Episodic memory helps the patient to remember his appointments, daily life schedule, or in general his meal times. Semantic memory supports his understanding and continue meaningful conversation, and procedure memory is automatic process like walking or eating. So a key point is all these types, these memories affects at different rates. So a person might be forgetting how to have a conversation but still be eating fine alone independently. Now cognitive communication and functional impact. So when a cognition is get affected, a lot of times we see topic drift, reduced coherence and increased pauses. But when we see that, we usually think that is a language problem, but actually it is cognitive in origin. Now we'll be looking at cognition audiovestibular settings. So when we say cognition is affected in audiovestibular system, because every balance activity needs cognition. If your cognition has declined, there is a higher risk of a patient or person understanding, and that's why there is a dysfunction. These are different types of disorders which will have cognitive difficulties. In Parkinson's disease, you find executive dysfunction and impaired dual tasking. That's why there is a risk of falls. In dementia, memory and attention deficits we see, which causes swallowing and communication difficulties. In stroke patient, we see attention and executive deficits. That's why there is a poor recovery in the rehabilitation, and that's why there is an unsafe swallowing. In mild cognitive impairment, subtle working memory deficits are seen, and those are actually early signs or early functional changes we see in geriatric population. I'll be talking about a cognitive load and dual tasking model. So what exactly dual tasking model is? Cognitive load is equal to mental effort required. What exactly? So when a person is talking while he is having his dinner, that times the cognitive load or reserve is more. That's why if the cognitive decline is there, he will stop or he will reduce the rate. That's when we can see that there is a cognitive decline, and this can be a very early sign. When a person fails on a dual tasking, we can see that there is a cognitive decline has occurred. So patient fails first in real life and then on papers. Now I'll be talking about cognition swallowing. So actually swallowing is not a only automatic process. It requires your cognition, attention, memory. So when a person, as I told, when a dual tasking model, when a person is told to do two tasks at the same time, there is high chances of aspiration. Why? Because there is a cognitive decline. When brain fails to predict, brain is always in the process of prediction. What is coming next? When brain fails to predict, there is discoordination happening. There is a delay in time. That's why we see the aspiration. And now finally, the impact and prevention of clinical approach. So there is a lot of impact that we can see: falls, aspiration, communication breakdown, or poor rehabilitation outcomes. But at the same time, there is good news. There are many modifiable factors also. So if we provide early hearing intervention, reduce cognitive load of that patient, improve their physical and cognitive health, and environmental modification. So disability, a lot of time disability occurs when there is a mismatch between individual and their surroundings. So if we provide a proper modification in the environment, this can be handled. Also, right now, when a patient goes, there is not an integrated approach. We only try to tackle one part of that because that person has come to you with that complaint. But if we provide holistic care, as mentioned in this, there's a lot of quality of life we are providing in better terms to the patient. These are my references. Thank you.
Hello everyone, good afternoon. Now we'll look into the communication aspect of our topic. And as the life expectancy increases, we see a significant rise in communication disorders among adults and elderly individuals. This communication is not just about speech, but it directly impacts the person's independence, emotional well-being, as well as social participation. So we can basically say that communication is equal to quality of life for the individual. Communication is defined like this by Asha, and we can infer from this that communication is a complex process which involves all the domains, which are the language, cognition, speech, hearing, social interaction. And so in elderly and adult individuals, disruption in any of these components can lead to significant communication breakdowns. These are few common communication disorders that we see, and these are few causes out of the many of those communication related disorders. Now, most important aspect here is the impact of these communication disorders on that individual. These domains are psychological, social, functional, caregiver, and economic related. Now, in the psychological aspect, the individual may experience frustration, depression, anxiety, reduced self-esteem, and even isolation in that matter. And over time, communication disorders can also reduce the cognition of that individual. Socially, communication disorders may lead to social isolation, withdrawal, reduced participation in family, work, and community roles, which can greatly impact the overall quality of life of the individual. Functionally, individual may struggle with their activities of daily living. They become less independent, communication breakdowns happen, which even increases the risk of understanding in medical and social situations. So communication majorly also involves caregivers because they impact the emotional stress in them, and caregiver burden increases because of the communication breakdown. In addition to all these, economic aspect of it is important because the treatment related expenses, rehabilitation, and long-term caregiving cost is involved in that. So overall, we can say that communication disorders not only affect speech and language, but also the emotional well-being, relationships, independence, and overall quality of life of the individual. These are the domains that we just now tapped on. So here, depending on the impact, the integrated care becomes really essential because the communication disorders rarely exist in isolation. Cognitive decline can lead to communication disorders. Hearing loss in turn also affects the communication disorders. SLP here so need to work closely in multidisciplinary team with all the team members, which includes audiologists, neurologists, psychologists, and even the occupational and physiotherapists.
This approach not only looks at communication difficulties, but also at the cognition, swallowing, hearing, emotional well-being, and daily functioning of the individual. Patient focus is an important aspect that has to tap on in this, which also includes family members and caregivers, which play an important role in rehabilitation process. So their involvement is encouraged throughout the treatment procedure. Regular communication among team members and case review also helps to ensure coordinated effective care. Depending on the patient's need, assistive technologies such as AAC and hearing aids may also help to improve communication and their participation in everyday life. So overall, the goal of integrated care approach is to improve functional outcome and quality of life by preventing complications such as the social isolation, reduced independence, cognitive decline, while also respecting the patient's cultural and psychosocial background. This is SLP's role and intervention strategies, which we are all well aware of. Now the most important aspect here to understand is the caregiver and family role. Caregivers and families play an important role in rehabilitation process by helping effective communication strategies such as simple language cues, giving the patient enough time to respond. In addition to communication support, they also provide emotional and psychological encouragement. They help improve the patient's confidence and motivation. Family members can facilitate home-based practice and encourage the individual to participate in daily communication activities. Creating a supportive communication environment, such as reducing background noise and distractions, can also make communication easier and more effective. Caregivers help monitor changes in the patient's condition, report to progress in the rehabilitation team, and assist in the use of AAC or any other assistive devices that the patient needs. Their involvement also helps to promote patients' independence while reducing frustration and behavioral difficulties that they go through. So overall, active participation of caregivers and family members in the therapy process greatly improves functional outcome and quality of life for the individual. So basically, we can say that communication is a fundamental human dignity and connection. Early identification and intervention combined with the integrated care approach can significantly improve their quality of life for the adults as well as elderly. And SLPs, we are not just treating speech, we are restoring their communication and connection. So this has to be an important aspect in that. Thank you. Now I call upon Ms. Ashral to deal on the swallowing aspect of the same.
Thank you, Kiran. So, my topic is reframing adult and geriatric care with respect to swallowing. So, in yesterday's session, mostly Bhushan sir has covered the management part of it. So, I'm not going to go in much detail with that, but I'll be covering few points. So, so these are my topics which I'll be covering in the presentation. So we all know that swallowing in itself is a complex mechanism. It involves more than 50 muscles which are required for swallowing with cranial nerve involvement. So in an elderly population, we see that there are a lot of changes, such as there is reduced bulk and strength in the tongue and near the pharynx. There is reduced bulk and sensitivity near the vocal cords, and there is decreased opening of the UES and longer and more dilated pharynx. So what do we understand by presbyphagia and dysphagia? So there's a minor difference between both of them, which we need to consider, because not every older population or elderly will have dysphagia. Okay, there is, because of the structural issues also, there can be issues, or you can see that there is occasional cough. There's loss of dentition, so that is why also they might have difficulty in chewing. It can take longer chewing time, the reflexes are slow, and because of that there can be some residue which can be cleared maybe with some tongue movements or by intaking water. In presbyphagia, usually there's no much difference in their nutritional status, as well as it doesn't affect their social life. Whereas in dysphagia, you see there are longer meal times, or there can be more of residue, and there's poor clearance also. Okay. There is also a complaint of frequent choking episodes, or they are at risk of aspiration, and which can lead to weight loss and malnutrition. Usually they have more of anxiety, which again leads to avoidance and avoidance in social life. So swallowing, as my fellows have already covered, that swallowing is an integrated function. It has a cognitive role in it. Also, sensory motor role is there, and environmental role. So while if you're taking a bite, it's a dual tasking, sometimes people do it, and that is why it can affect their swallowing. Whereas coordination and timing, we all know that it is an important aspect when we are initiating a swallow. Usually, a lot of time in elderly population, you see that they are watching TV and then eating. There's noise, there's distraction. So in these cases also, it can lead to swallowing difficulties. The other hidden factors which we see in swallowing is that, as Snehal has informed us about cognitive load, so our brain gets tired. In elderly population already, they have a lot to bear with. So usually if they are tired, it can lead to confusion, which can affect the swallowing. Sarcopenia is, you can say that it is a loss of skeletal muscle. So in swallowing, this has an important role. Polypharmacy, usually in an elderly population, you see that they take a lot of medications, may it be because of diabetes or BP, or if they have any other comorbidities. So this can also lead to dryness of the mouth, or you can say that there can be drowsiness, which can impair their swallowing. Usually they get tired if they are walking, or if they are doing some task, they get easily fatigued. So that can also be a factor if we are going to check with swallowing. This is a part where Bhushan sir has already covered. So in management for elderly population, it is important that if we already know if they are having comorbidities, it is important that you can start before. Early intervention is something which we can take forward, like if there is Parkinson's. So you already know that they are going to have, in the later stages, they are going to have difficulty with voice, and they might have difficulty with swallowing. So you can start prior, like you can prepare for that, and you can take a collaborative decision for them. Like the caregiver, the patient itself can participate in taking a decision, and we can work on their quality of life. So as Snehal and Kiran both have covered that everything has a psychological impact. Okay, so but in swallowing respect, if there is they have fear of choking. So if they are going out somewhere, so that can impair their, it can create anxiety, which will lead to avoidance, and it will affect their social life and their confidence and the overall functional abilities. I will just like to cover on palliative care. So a lot of time at the end stages, I would say, they have this difficulty that they have already gone through a lot, like they have this RT, or with medications, or a lot of medications, and physiotherapy and other so like if they are again having speech therapy, cognitive therapy and everything, so that again affects their psychology. It has an effect on psychology. So in these cases, we need to make sure that we are ensuring the safety, as well as we are focusing on their comfort and their functional abilities. So they should have this meaningful dining, and we can also accept that sometimes we do have to take risk while feeding them. definitely you can take a consent before that, because otherwise you will get into trouble. But you have to accept that we have to maintain their quality of life also. So these are the points I wanted to cover. And summary, that dysphagia is something that is not an isolated issue, and you need to assess their cognitive function, their mental status, their strength of the muscles, and the overall functioning. You have to focus on the function, the participation, and the quality of life. You have to see that if you already know that there is going to be a difficulty, you move on to a proactive management care. And also in palliative care, their comfort and dignity must be our priority. So thank you.
Thank you all the presenters. So I would like to know from the technical team that how much time do we have? Because we have a panel discussion also. I think we have finished our presentation in 35 minutes. 10 minutes we have. Okay, fine. So we'll move on to the panel discussion part. I think Shamangi, she was telling about the insurance part. So I would like to know more about how much this insurance can help for an individual with a hearing loss, or the, if you look into the audio vestibular rehab part.
Yes, so this has been my recent favorite topic in the clinic and fighting with the insurance team. Lately, for cochlear implant, there are two aspects to it. One is diagnostic, one is product-based, and how they can cover up under insurance. When it comes to a patient who's been referred from a particular hospital or anyone and is under a care of GP or ENT neuro and tells ki because of so and so reason we need to do a hearing testing, or I want him to be evaluated for impedance. Whatever minimum cost, the patient would like to claim it under insurance. So it is always a reimbursement, it will never be a cashless. So in that scenario, if there is a written note or a referral from the main referring doctor, you do it, and when you submit it, there is the way you document your receipts, and sometimes the insurance companies do come and ask you for your RCI and the clinic credentials, like if you have your Kumasta, GST, and Udyam Aadhar. If you have all these three, your receipts are eligible and there can be a reimbursement. And for cochlear implantation, when you give a GST, or it is completely based on the insurer, like Star, pathetic, widely opening and telling pathetic. There are other insurers like Niva Bupa, they are HDFC Argo, New India Insurance. They are covering almost 90 to 95% of SEI care under insurance. So if an implant is costing you 20 lakhs, my patients have got reimbursement of entire 20 lakhs. So we should be aware, we do not talk. Hearing aids are not yet considered under insurance, unfortunately, but CI is. So that can be, it is inclusive of your rehabilitation cost also. If you make a package of the number of mappings and therapy sessions which you're going to do and give it to the patient, they bill it to you, that can also be covered under insurance for the patient. So it is a big relief for the elderly as well as pediatrics.
I think everyone should make a note of it so that you can inform your patients for regarding the insurance. So in speech, Ashral, the same question I want to ask you. So do you have anything, which the neuro rehab part which can be covered under insurance?
So usually insurance, if the patient is hospitalized, it usually gets covered, but you definitely need a referral from the neurologist or the concerned doctor. So based on that, we can start with the rehab, and then it can be covered if you're hospitalized. Unfortunately, in OPD basis, it is not much covered, but there are different associations which can reimburse the amount. But again, as Shamangi Di have mentioned, that documentation is something which is important. The receipts and everything is required, even if it is on an outpatient basis. So you need to have the documentation so that they can apply for the reimbursement. So like Multiple Sclerosis Association, even that society, they do provide some amount for the rehab part. Let it be physio or let it be speech, but that can be covered in that. There are some amounts, but it has limitation.
Also, this is one part which we are talking about insurance, but also there are government schemes which also provides you some kind of subsidies. But for that, every this patient, like a patient with a stroke, they need to apply for their unique disability card, UDID. With the percentage of their disability, they can apply for that schemes whatever governments are providing. So make sure at least you are telling all your stroke patients to apply. They require a year of therapy and then the severity is decided. So make sure you are creating awareness and making sure each one of your patient is going and applying so that they are eligible for all the travel schemes, government schemes. Thank you.
Okay, fine. So, what are the medico-legal aspects like when you look into the ASLV practice? What do you think? Because the client is been, admitted, and you have, like, as you said in your presentation, there are risk factors like aspirations, choking, and all. So, how do you think?
So exactly. So in speech-related aspects, if we see, so majorly complications you can face is while assessing swallowing-related aspects, because they are at high risk of aspiration. Patients can directly, even if it is their negligence, they can still complain, and it can come on your head. So it is better that you have everything documented. Even in the hospital setups, usually things get covered by the administration itself. But from your side, it is important that you take care. You also have your a personal indemnity insurance done. So that will help you to avoid any further complications. So that is one thing. So
So, one more thing in that, like most of the neuro cases which you see, it is like home-based. The therapy is, you make a home visit. So, how do you think that can be managed?
So,
like for the medico-legal aspect?
Again, if we see that a lot of times we ask the caregivers also to contribute for the feeding part. Like if you do the trials and all, you ask them to do it. So again, as I said, documentation, even if you are doing a home visit, it is important that you taking these into consideration. Proper reports, your assessment reports, and the further whatever you are advising. It should be in a written form. If it is in a verbal form, no one would consider it. So you need everything in writing. So that is the only thing which we can take care.
Just to add on what all Ashrali said, consent is, I feel, an important aspect that we have to really make sure. An informed consent is really important rather than being a consent. Just that they are informed about everything. Otherwise, they'll be like, yes, we were asked to sign something, but we exactly don't know what it was. So an informed consent is also a very important factor that should be tapped on during documentation part to avoid any medical legal aspects of that.
That's right.
Okay. So, Kiran, it's for you. The therapy goals which we decide, so is it different, like, when you do the therapy at home or in a hospital or in a clinical setup?
Yes, definitely. At a hospital setting, at a rehab center, or at home care, it does differ because the patient's condition is different at all levels. I feel at a hospital setting, these are immediate and short-term goals, which basically focus or we aim at patient safety and stabilization initially. And in the home setting or at a care, these are few mid-term goals where mostly patient functional outcomes or functional restoration is what we basically focus. But in a long-term plan, that is at a care setup, participation and independence of the individual is focused there. So we look into long-term plans there rather than at a hospital setup into short-term plans. So of course it does differ from a setting to setting based on an individual's condition and that.
Okay. So Snehal, do you want to add something? Fine.
One more thing I would like that in home care setting, usually it is the comfort zone. So you can do a lot of things
in a functional environment, which can be restricted in a hospital or a clinic setting. And also you can see that how the caregiver is participating, because it's not a one-man thing. We need a contribution from the caregivers, otherwise a 45-minute session is not enough for the rehab.
Okay. Yeah, thank you so much. I think, yeah, we are done with our presentations. So thank you for your patient listening.
Thank you for a very insightful and enriching session, and which has helped us fill in the gaps about where we are lacking as audiologists and speech language pathologists in providing intervention to the geriatric population. I'd like to ask the speakers to wait back. I'd like to invite Dr. C.S. Vanaja ma'am on stage to felicitate the speakers, please, ma'am. Moving on to the last presentation of the day, which is a panel discussion. And when I look at this, the topic for this panel discussion, I feel like we've completed an entire cycle. I remember how we were having a discussion in the first session yesterday, wherein we had speakers saying that, usually the scenario or the picture today is that most of the audiologists and speech language pathologists are trying to venture into private practice simply because of the monetary good picture that we see there, right? So bearing that in mind, I think this is the perfect end to the conference. The topic for the panel discussion that we're going to see right now are mistakes, milestones, and money, real talk on private practice, which is a session moderated by Ms. Swati Bhatt. Ms. Swati Bhatt is the founder of Earbuddy Hearing Care in Goa. She has had 6 years experience as senior clinical specialist at Medal India, and she's currently been working from her clinic since the last 5 years. She also has to her credit a published paper titled Effect of Age on Caloric Test, Gaze Test, and Vestibular Evoked Myogenic Potential. So I would please request all of you to applaud for her as I invite Ms. Swati Bhatt on stage.
Hi everyone, good evening. My name is Swati, and I'm going to be the moderator for the last session of this amazing conference. I do realize that this topic seems maybe a little awkward for all of you all, because how many students are here? Raise your hand. Wow, so many students. Aarti ma'am, And how about, how many private practitioners? Lovely. How many people doing jobs? Okay. Now, you may look at this and think that, अरे मेरा क्या लेना देना, मैं तो जॉब कर रही हूँ, या तो मुझे क्या बाद में कर लेंगे. But let me tell you, today on this panel, there are 2 people who are doing job in MNCs and now are doing private practice. Some people got married and then they had no choice, they had to do private practice. Some people then they inherited something and then private practice. So today we're going to see how you can plan your life, but then ultimately you will reach to private practice. So let me introduce everyone who's going to be here today. First, I'd like to call up Mr. Sadanand Gore. He is an MASLP clinical audiologist and speech language pathologist. He's worked as an audiologist in Manke Hearing Services. He's a founder of Gore Hearing and Speech Clinic. He's also a founder of Hearing Aid Conversion Mastery Program for audiologists. Then I'd like to invite Mr. Sunil Patil. He has over 15 years of experience in the field of audiology. He has represented national level ASLP conferences and he runs his own center called My Speech and Hearing Center. Next. I'd like to invite Ms. Urvi Mehta. She's the founder of Bologram Speech Therapy Center in Mumbai. She's also the senior SLP at Visha Therapy Center in Mumbai. She's an experienced pediatric speech therapist, also my classmate. Next, I'd like to invite Vedanti Patil. She's a consultant audiologist and speech therapist at Speech and Hearing Center, consultant at various others pediatrics and ENT hospitals as well. And lastly, I'd like to invite Ms. Akanksha Chitnis Gupte. She is experienced with Hanen More Than Words program, Hanen It Takes Two to Talk program, OPT, prompt, and much, much more. So today, I would like to say that this looks like a panel discussion, but all of us are classmates, and I feel as though we're just going to have a discussion how we used to do in college during the canteen tuppary, right? When we had our dreams, and today we are here fulfilling our dreams. So we're going to keep it light because it's the last day, everybody is tired, and we're also going to give a lot of a lot of information, so they are motivated to be private practitioners like us. So I'm going to start with, let's start with Urvi. So Urvi, let's talk about mistakes. Looking back at what were some early mistakes that you had made when you just started your private practice?
Okay, I will start with you need to make mistakes so that you know where you can actually land, okay, in practice. The one thing that I think we all should understand is that you cannot start your practice right, soon after you graduate. Because you really need to learn how do you handle cases in private centers, how the private centers are run, how do you not burn out yourself while you also keep yourself educated every step of the way, because only opening a center again is not enough. You need to keep updating yourself, you need to keep updating your knowledge, and also you must learn from the co-workers. So one of the mistakes honestly I made was that I just sat at my dad's clinic and I'm like, okay, I'll be a speech therapist here. That's not enough. You need to learn, you need to go to a center, you need to learn from a mentor that you think that this is the person I want to look up to. I like the way this particular professional is running the center. I'm going to make certain things in my mind that, okay, these are some of the things you need to take care. First step, if you want to open a private practice. Second, also one thing that I really like, I really want you to understand. Yeah, I want everybody to learn is that you also need to understand that you cannot overpromise yourself just because now you have a center. You need to learn, you need to go gradually, you need to progress in such a way that you also learn, you also make sure you have a stability in practice. We can have everything under one roof or we can have one service under one roof, but the only difference is that you should not be overpromising or you cannot just fly around. It is very important that you learn from the professionals also. You go gradual, it'll take 5-6 years for you to have a better practice, a good practice, and I'm sure you will all earn money, which I think Sadanand and Vedanti is going to cover about the money part, which I think everyone
Money
wants to
definitely takes time, but then you'll have to then go about it.
And speech therapy is, I think, it's a time-consuming process, to be honest, in a long term as well.
Correct, 100%. Okay, so then now that we've started, we've made our mistakes, let's see how we understand where we are. So, Akanksha, tell me, when you stepped out of college, so when we are in college, we have a particular mindset, right? But when we step out of college, what expectations did you have? And then when you really started working, what did you really get?
See, one thing is once you graduate, it is obvious that you believe that you are ready. Trust me, you're not. Okay? So you'll have your protocols, you'll have your assessments and lesson plans and everything ready, all right? And I did too. And then you see real families walking through that door, okay? And when I started off, I just started with this belief that if being a good therapist means having all the knowledge, all right? So you'll structure your sessions, you'll have your lesson plans, and you'll think of an ideal session, how it is going to go. And then the child walks in, all right? The child does not know anything about our protocols. You see a family. You see a mother who's anxious. You see a father who's grieving.
No, 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 no. Use the mic. Give the third mic, no?
Yeah, so entire family system is chaotic, okay? So we need to keep that in mind. We need to acknowledge that first before we do anything. So long story short, therapy is more relational first and then clinical. And once you understand that, I think things start going on track. So that's one
Wonderful.
thing that I take.
Perfect, perfect. Now this is with speech. Let's think about audiology. When someone starts building a private practice, is it easy to only focus on patient numbers, or how is it that you would really define growth? Sunil, tell me.
So definitely it's not about the numbers, because your numbers are going to keep you busy, but the kind of impact we are going to have in our client's life is going to define our success. So over the period, our goal should be towards making patient satisfaction, and that can happen only through two ways. It's not by seeing too many patients in a day. It will happen through whether we have a good number of time to talk to patients. And also we have supporting technology wherein your patients are benefiting it from, and that's what will define your growth. So over the time in our clinic, we had a goal wherein we will see less number of complaints, less number of unsatisfied clients, and happy patients basically. So that should be our growth in our private practice. So focus should be always about how we are improving their quality, and not about seeing too many patients. One can have too many patients and feel that I am busy all the time. We can say that way, but at the same time, how many quality patients you have. So yesterday we were having a discussion with Swarup sir, and he also had one good thing to say. He says that I see very limited patients, but I'm satisfied with them. That's how your goal can be. Your goal need not to have.
Ultimately, money is reality.
Yeah.
So let's go to money now. So Sadanand, you can take this up. Now, in the initial phase, how should a clinician think about setting realistic financial goals and preparing the groundwork? Because when we start, we know that it's so much scope and all that. But when we actually started, how should we keep our realistic goals?
Yeah. So it is a good problem to have actually. We can have quality time with patients and all, but you should have first patients. Okay. So imagine you start a clinic first. So I started after the job. So I already had expenses of my own expenses. कार का EMI चल रहा है, घर का EMI चल रहा है, बेटे का स्कूल का खर्चा चल रहा है, and then you on the top of that you have clinic का rent. Okay. Forget receptionist, I could not afford even the maid. Okay, so first 4 months खुद जाने का, साफ करने का और बैठने का. That's all I have done. Yeah. And within 4 months, I was kind of a bankrupt. So July I started, July 2021. By October, I had zero money. I had to borrow from him. He was kind enough to give. So initial challenges will be there. It is not a smooth journey. Okay, but I was decided that I want to continue the private practice itself. And I worked on my sales and marketing. Did I miss your question? Sorry. What was the question?
That's it. Then now let's see, Vedanti. Yeah. You can continue with that. So as your practice now, he started it, wo saaf karke baith gaya, but now it's going to start. So as the practice grows, how do you manage your daily financial decisions? May it be your cash flows, expenses, or anything else. How do you actually manage daily tasks?
Okay, I think the initial clinical years are like the power play of your match. So you need to decide accordingly. And first of all, I would say that you analyze yourself, what are your strengths and weaknesses. So when I started with speech because it was my strength. And then when speech was stable, I slowly started focusing on audio as well. Then there was a time when audio was primary and speech was constant, speech was stable. So there has to be one steady thing which takes care of all your rents, your expenses, your overheads, stationery, or बहुत सा छोटा मोटा खर्चा. And then you can shift your focus onto other things.
Brilliant. All right. So now again, let's come back to mistakes, because mistakes is something that's absolutely ongoing, right? We're always learning. So how did those experiences change the way you think, decide, or communicate with patients today? Whatever mistakes you did, how did it shape you today?
So initially what happens is when we directly start into our practice, we get conscious to speak to other team members. And at times you forget that it is okay to ask certain doubts. Like for example, if you ask me personally, I did not know much about occupational therapy. I had no idea why do they work with us, because I almost felt like they are taking our opportunities away from us. But then it made me realize that it's not about who is working for whom or who's taking whose cases, it's about a team approach. So initially I also made a few mistakes where I did not really approach, I did not try to learn. But then now I realize that it is the best way to work for, like for example, I'm in a pediatric practice. This is the best way to work. I want to ask the otist question. I still ask about sensory processing issues because I still don't understand. And if I do, then I want to know more so that I should know that how am I handling. It also makes it very easy to talk to parents because then all the team members are on the same page when you're talking to mothers, fathers, parents, or caregivers or anybody, because that's what exactly we have been talking also in our 2 days conferences. It's about holistic. It is also about teamwork, team frame. That is where I think over a period of time we happen to improve. And again, you would not want to overpromise your patients.
Correct.
Okay, like you do not need to give timelines. It is not important. Like for SLP, I think we would agree that we don't have timeline. Okay, we cannot give anybody that for how long is your patient going to take to improve. No experienced therapist in the world can give you that. So I think there are certain things I learned over a period of time, and I think
and that was a milestone when you know how to speak to them.
That's the milestone, I believe.
So tell me one key milestone that truly changed how you practice and thought as a clinician.
One thing is the first, so key milestone, I'll be just breaking it down to 3 milestones, okay? So first shift that will come is once you stop looking only at the child and also start looking at what's happening around the child, okay? That's really, really important. The next, because what happens is once you cross like 2 to 5 years of your experience, you'll start noticing patterns. You'll see certain kids are excelling, they're doing really good, they're picking up. Some kids will plateau, all right? And often it has nothing to do with the diagnosis or the frequency of your sessions or your technique or approach. It has a lot to do with what's happening at home. And once you notice that, you see there's a calm parent at home, there's a father who's not correcting too much, the home is less stressed. That's milestone number 1. Second milestone is when you start realizing that parents are much more than offering just home programs, okay? Now again, a little controversial over here, but I'm still gonna speak it out. What happens is once you start making parents aware of their own patterns, okay? How does the parent feel when a child is struggling, okay? Where is the parent's fear driven from when the child is having an issue? Now once we start addressing that and we make that space for the parent, it becomes much more easier for the parent to realize, okay, this is happening within me and this is what I need to take care of, all right? The third milestone will come when internal changes start happening within you. Things start getting so spontaneous that once you step into the room, you know exactly what is the environment in the room. Maybe the child is woken up early. Maybe the child is not eaten enough. Maybe the husband and wife have fought. Maybe something has happened, all right? And you know how to change your session spontaneously. You might have a plan in hand that, okay, today I'm going to work on da 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 da. No, that cannot happen. So you will get quick enough to fatak se change. Oh, today, you know what? Let's keep this aside. Let's just go have fun. And you're still going to work. So I think these are the milestones.
You have to be impromptu and you have to be.
Yes.
So, but all of this keeps you very busy. But sometimes we realize that we're working all day, we're busy all month, but where is the growth? Sunil, would you like to take this up? Like, how do you differentiate between actual growth? How would a clinician know whether I'm growing or I'm just busy?
Okay, so it's a simple, you'll start earning money, it is your growth definitely. So, but while growing, a stage comes wherein, you know, you start investing in your working place a lot. That is where I feel that that's also growth. Because many of my friends I have seen and my colleagues I have seen, they would like to earn from clinic and they invest very less in their clinic, which I feel very sorry about it. When I see the kind of clinic infrastructure, the equipments what they have, the computers, why don't we invest in our clinic? That feeling of growth will come only when you will feel that you are investing in your clinic. Buy good computer, lakh rupees computer, 2 lakh rupees computer. It is going to give you good performance all the time. Buy a good audiometer. You'll feel better when you sit, test the patients. Yeah. Buy a good Bera. Have all the tests in your clinic, whatever possible you have them. Hire very good receptionists. People don't invest on their receptionists.
Brilliant.
I can define what is good.
Definitely is how we know how much Sunil's audio meter, laptop costs, and we also know he has a very good receptionist. I'd like to ask Vedanti, tell me, how do you look at investment, reinvesting in your own clinic? See, we know Sunil's path now. Now we want to know yours.
Okay, so for reinvesting, in the first initial year or two, I think you get a clear idea of what is your current caseload, what kind of referrals you are getting from your referral sources. Because if you are approaching 10 doctors at a time, nobody is going to send you patients right away. It takes time to build that rapport and prove yourself. So once you get that idea, then you can decide the direction of what is your most needed instrument or software, or it can be your interior, anything. So decide that and then only invest accordingly, because you need to have that clear idea that I'll be able to recover the instrument cost in these many years or these many months, and my return on investment is going to be good down the lane. So that confidence you should have, because don't increase your liabilities. And one more point I would like to add is, if you are practicing both speech and audio, there are comparatively more fluctuations in audio practice. I think everyone will agree here if I'm talking from a rehab perspective or hearing aid perspective. The first thing is there is cutthroat practice and heavy commercialization right now. Plus seasonal variations are there. For example, monsoon season or this season, if you consider, the patient load is less. Even the ENT OPDs or other OPDs are also slow, so which will ultimately affect your caseload. So there has to be one steady thing which takes care of all your expenses. And don't go into losses. That should be your goal number one, right from month one.
Brilliant, brilliant, absolutely. Okay, now we know that we've seen anxiety, we've seen money coming, but now we also want to stabilize it. Because we've seen in our profession that when it's raining, all the kids are having sardi zukam, then speech is having its issues, or if it's not business season, then we don't have hearing aid sales. So we've seen this little disparity, but we have to keep constants, right? So I want to ask Sadanand, is there any way, what systems or habits or what frameworks should we actually use so that we can maintain stability? These systems and frameworks help you in all parts of life, so please listen carefully.
Okay, so in audience, how many of them are earning right now, job or business? Okay, how many of them know their exact expenses and income every month? They are noting down the expenses. Okay, great. So and in a business, we should know our personal expenses. We should know our business expenses. Not for the ITR purposes, but for our own revenue thing. Okay, ITR में आप कुछ भी बाद में डाल सकते हो. That's up to you. So there are apps also. I use Money Lover app since 7, 8 years. It's a very nice app. So every month, every quarter, and every annum, I know how much expense is happening. So to get the proper financial freedom, first keep account of your expenses. You should know how much is coming, how much your business is consuming every month, and once you have some extra amount of money, for everybody it is different. For somebody it wants comfort, so they may go for maybe a new iPhone model or maybe a Thar car. It depends. For me, it's a freedom. So I put it in such a way that it grows money. So yesterday night I was calculating, okay, so I can go for 5 years of holiday. Even if I don't, there is no revenue for 5 years, still on 6th year, my clinic will be working. So you can, whatever money comes, like Govind was discussing with Dr. Bell sir yesterday, ki what to be done, like people don't understand what to be done for the extra money. So instead of taking up liability, see if you can invest into assets in such a way that even if such fluctuations happen in the business, you are not worried, and you can take a holiday. For example, now I'm 3 weeks, I'm not in the clinic. Reality is not there. So I'm not worried about it because I have the expenses. I can take up that loss. I have something else to do. So like this, if freedom is the currency in your life, if you want to looking for, then definitely invest in good assets than purchasing the liabilities.
Okay, so now that we all have got some good financial advice, let's again come to mistakes, because who doesn't make them all their lives, right? Now, that we are coming towards the end of our whole presentation, I would like to have what are the mistakes. For now, we're going to talk about people who are planning to start off, right? So Urvi, I want you to tell them, as in for someone who's just starting off, what would you want them to avoid or do differently from day one?
Okay, so first thing is, as I said, first thing is you really need to work first somewhere else and understand how the private practice runs, number one. Another thing that I think it is most important is also that you do not need to burn out just because now you have a practice. You need to time your sessions as it is needed, because you also need to understand that if you overwork with your sessions as far as speech is concerned, we eventually will have laryngitis, we will have nodules, we'll go on a 10 days holiday, khatam ho gaya. That is not going to help. So I think the most important is also to make sure that you understand the value of time for yourself as well, and you know how to make sure that you are at least sustaining your practice. And the most important thing is the teamwork, because I have enjoyed teamwork throughout, I think, the time, and I find it very difficult to work alone. I would always like to trouble the other professionals in order to make sure that we are all on the same page. And I think this is one of the most important thing. Let it be physiotherapists, occupational therapists, remedial educators, anybody that you work with, you must know that every child is on the same page as far as all the professionals are concerned, and which is the most important. You do not need to have all the professionals in your center or someone else's. You can also collab with these professionals elsewhere. Probably you can, share a patient with other professionals who are working in their own setups. That is also easily possible. We do not need to find a big place, no big rents. Find your own place, and I think work collaboratively.
Superb, superb. So now again, this last take is going to be just a takeaway for all of y'all, all right? So Akanksha, I want you to tell them a little bit about the hard truth that we don't really talk about. So what are the hard truths about early years that no one talks about, but every clinician should be prepared for it?
I would say when you start off, right, one hard truth is it is very easy for us as a clinician to tie our self-worth with the outcome that we see. So if a child is doing really well, there's progress, you feel competent and confident. But when you don't see progress, we question ourselves, all right? But you always remember your 45 minute session can never carry the load of a child's life, okay? That's the first truth. Truth number 2, not all families are going to be ready to receive what you want to offer, okay? Because that's a protocol. They go to the developmental pediatrician, they'll come to you, they know nothing, all right? Very few are ready to take what you want to offer. Most of them want quick fixes. Some of them will resist. Some of them will question. They'll have their own emotional load, all right? and it is okay. Give them the time to process and come back. The third truth is, how many of y'all feel that working with kids is really easy? Okay, I used to think working with kids, easy job. No, it is not. Because working with kids will open up such parts of you that you never know existed. Okay, it will take you to such deep reflection. All right, and you will not know why you are reacting the way you are suddenly. So take time, because if you don't do that work on yourself, that what you are carrying shapes your work, and that is not pleasant. So I think those are the three things you need to be taking care of.
Definitely. So as you're doing private practice, you're also maturing, but so is also the clinic. Your clinic is maturing as well. So we are building systems, we are building visibility, we're building financial stability. Sunil, would you like to tell us that what milestone would signal proper growth, that I would know, okay, yeah, now I'm at this point of life? What would you say is a very solid milestone?
So, very simple.
At what point should I party that, okay, I've reached here? You know, that point I want you to tell them.
Simple way to put it in this way, like when your existing referrals, that is your organic growth, overpasses your marketing spend, that will show your actual growth. So when you are doing ads, you will get certain number of patients every time you invest in ads. But a stage should come that your organic patients should be so much that you are hardly have to spend, because you are not spending for that. So over the period, like at today's stage, our organic growth is, I can say, 70% of our practice is organic. Like our existing patients are referring, you know, so that way. So and also you should be coming to at such stage that, you know, you should be known for your work. So like most of the time, I'm proud to say that, you know, all these maybe any fellow professionals or some hearing aid manufacturers, or if somebody from their relatives, somebody, if they have to refer their own family member, their friend, so they send it to me. So that's such, because they have many dealers in the Pune, but they send it to me, so that I feel that, you know, that stage should come in everybody's life, that you are being known for your work.
You're the first person they think about when they think about hearing aids. Vedanti, you want to comment on the same thing regarding speech therapy? Like what milestone would you say that, yeah, now I've achieved, now I can party as a speech therapist?
So I think as Sunil sir said, and as I also mentioned earlier, if you are asking 10 doctors and going and meeting 10 doctors, everybody is not going to send you patients. Which takes you further and which makes you grow is actually how genuinely you are offering your service and how quality service you are giving. So that shows patients also how caring and how loving you are. And word of mouth is the best publicity, I think.
Brilliant.
That's what makes the real milestone, when you start getting your own referrals on your own name.
Yeah, and that's when you know that you're working long term. So when you're thinking of long term financial security in private practice, Sadanand, would you like to comment on what are the things that you should not negotiate? Like these are non-negotiables and ye to karna hi hai.
See, for me, it's always been, as I said, ki financial security, financial literacy is most important. So once you have you started the practice, you have some extra fund, keep it aside. You can keep it in FD or something. Make 6 months of funds separate, so that now you have financial security. So to some fluctuations now you can still manage. If you get extra funds, then keep 3 years of funds aside, so that now you can do long-term planning. You can take a little bit more risk. If you want kind of clinic shifting, clinic upgradations, you can do all these things. Ideally, you should be investing in such a way that the clinic is not running on the clinic's income, but clinic is running on the clinic's money where it is invested. So it is running on a more of a passive basis. Okay. So financial literacy is more important. If finance are settled, then you can party, you can go for the trips, you can build bungalow. But if the if the finance is not set, it's not about the revenue. Okay? It's in the end, how are you planning your finances? If that is not done well, then you may not be able to pay your home EMI also. Okay, so make yourself financially disciplined first, and see if you can do more of into being more into assets than just. I mean, I am okay with driving second-hand car. It's okay. I mean, staying in the rented house. It's fine for me. What is still most important thing is, do I have a 5 year of runway for my clinic? That I am secured. I feel I get good sleep in the night. Okay, so it's about that. That's what I feel. For everybody, it can be different. So as per your own preference, you should have your financial goals.
Okay. So now that we have another 15 minutes for this whole thing, I have kept some googly questions for you all, and any of you all can take it, okay? But there's a little bit surprise element, or else it looks very scripted. So now, let's go for what is the most unexpected challenge that you faced while opening your clinic? Like you were like, ye kya ho gaya? I'm sure it happened to all of us. Which one do you want to talk about over here? Who wants to go ahead? Sunil,
I think
go.
So for initial timing, it was when GST came very new, 2018. Yeah, that was the time when GST also came. I had to open my current account, and these both guys, bank people, they were asking me that without GST certificate, you can't have your current account. And when I went to this one, GST guys, they told that without current account, we will not give GST account. So that was a simple challenge I had. So how will I start now? So somewhere I managed one bank, just somehow open my current account so that I can get my GST certificate, because I wanted in certain desired bank, and that bank was very adamant about it. So that was a chaotic situation that time, but somehow.
Yeah, you'd be surprised actually. The one thing that's very irritating is how banks can irritate you. Like when you're doing a job, you know that they'll happily give you a bank account, right? But here they'll have 10 questions, then registration, then you have to go to panchayat office and then fight with the sarpanch and whatnot. Somebody may have done it, so I'm saying all of it. But all of this does happen, right? Okay, now one more thing. See, ultimately when you're doing private practice, you're a business owner. You have to have some skills of business, right? So have you all invested in networking or mentorship, or have you put any money into learning business?
Yeah, can I answer that?
Yeah.
Yeah. So as an audiologist, we are not taught much about the sales and marketing part. Okay, and these are the two most important skills we need to learn. So personally, I have invested thousands of. Even he says no, don't invest, but I learned a lot through sales. There is a psychology of sales and also neuroscience of the sales. How sales happen. There's a process for it. If you can crack it, your conversion rates improve. At the same time, marketing is something which keeps on evolving. Okay, now Google was there, now AI has come, you have content marketing. So with respect to marketing also, there is a lot to learn. So I have personally invested a lot in understanding. That's why I keep roaming with camera all the time. So because I believe in marketing, okay? So I understand what the importance of a content creation. So I have for my clinic YouTube channel has crossed 5 lakh hours of views. Okay, so from there we get we have done a lot of free consultation across India. Now we have stopped free consultation because we are getting almost 10 to 20 calls every day. So content marketing is something which I have implemented, but for that you need to, again, it keeps on evolving. Now 4 years back it was long form. Now it has come to short form, and short form also keep on changing every 3 months. Yeah. So you need to keep on updating yourself, specifically marketing, and the way of selling. We are saying cutthroat marketing competition has come. So how do you create your own USP? How do you differentiate yourself from the other? It's not about being better. It's just have to be.
How do you stand out? How do you stand out?
And then you win. That's it.
Okay. So now that we've heard from all the panelists, it comes back to me. I know I've added a lot of humor because it gets boring when you look at it as in this is not mine, but humor belongs to everyone. But now coming to something serious, private practice is not as, it's not as, the word is easy as it looks. It's not as glamorous as it looks. We've all had sleepless nights. We've all had times where we don't know what we're going to do next month. We don't know where salaries are going to come from. It's anxiety, it's difficult, but you can pull through. You have to invest in education. You have to keep learning. But there's always one thing that you should know. We are your seniors. We've already struggled. If y'all are going to struggle the same thing as we, then our struggle has no value. Please pick up the call and call any of us. We will definitely help you, give you tips and tricks. You make new mistakes. You build new milestones. Don't do the same thing that we've done. Or else our struggle and our sleepless nights will have no value. Okay? That's one takeaway. Second is please collaborate. We are not each other's competition. There's a lot of abundance. In this market, there's a lot of abundance. Collaborate with each other because we all have different strengths. Collaborate with other professionals. You'll realize that everybody's working, occupational therapists, psychologists, everybody has the same problem. If we all get together and together solve the problem, we're not only benefiting the child, but benefiting ourselves as well. Okay, that is another. And last is, wait, sorry, my iPad just got locked. Okay, and the last is, yes, please call us. We're here. I'm on Instagram. Check it out. I'm going to use this definitely. My contact details are there, but we're always there. We're always very friendly. We're always together helping each other out. We're more than happy to help y'all as well. So saying this, I'd like to conclude. If there are any questions, please go ahead. Any questions?
Yes, Ronali.
Give the mic.
So when I started my private practice, there were suggestions that could you go niche in some particular area? So I wanted to know from the experiences, like, was this a suggestion that came across any one of you, and did you consider it going niche only with pediatric or only with voice or only with hearing aid fitting? Was it a choice that any one of you has made?
Yeah, so I think you should do everything, but market yourself as niche. That's what I follow.
Okay,
if you can do it, everything. But when it comes to market, when somebody sees, you want to seize in particular area, suppose hearing aids, so they should see you more. Or suppose neuro speech, they should see you. Then it becomes, then you become premium in that. If you're seen everywhere, then they said, then it is not considered as a specialist. That's my opinion.
I honestly explored that part that you are talking about. I took adults also, I took dysphagia also, I took everything. And eventually I only realized that probably I am not comfortable exploring everything. And I think I was more interested into pediatric, and I think it's been now, what, 10 years? I'm only in pediatrics whatsoever. So I think what you're asking, I get it. It's not a suggestion, but I think I did realize in the first 3 years that probably I may not be truthful to myself, and I think it makes no sense that if you are not confident, it's okay to let it be. It's okay to say no. It's okay to be, denying that, okay, you know what, maybe I'm going to refer you to my friend. Please, she's the best. Maybe you can ask help from another expert. So it's okay. I think it's fair.
I think it starts with discovering yourself. See what you want to be good at and then be good at it.
Also, I wanted to add on, when you're selecting your niche, even into that, you have to be very careful and look into what is it that is not there within that. So, for example, autism, everybody is now talking about autism therapy, different types of approaches, all of it. Even parent training. I don't know how many people, professionals are talking about what's happening at the parent's side. That's how I selected my niche. That, hey, you know what? I know all of that and I will work with that, but my primary problem was, in spite of me learning everything and wanting to give so much, if the parent is not ready out there, I cannot complain, hey, the parent is not ready. No. What can I do to make that parent ready? I think that will also help.
You have one more choice. You can choose for yourself to begin specialize in certain thing, and you can have a specialist people along with you, so that your practice have all the good people with you, and then that's how your clinic will be known in certain areas as well. That also can be your option.
I'll just like to add one more perspective, because if you are new and your setup is new, you cannot just deny patients. You cannot say no to referred patients. So you take at least 2 to 3 years to find your niche, to find your liking. But if you want to take care of your daily expenses, and if you don't want to go into losses, you should take all the patients in the initial years at least. That's what I think.
Do we have any more questions? Students, come on. One question.
I thought money will be interesting for students.
Yeah, that's what even I thought the same. Or at least my Instagram handle would be interested for them. Nobody asked that also. Come on, ask a question. We have 5 minutes to go. All right, fine. So I think there are no questions. I did promise everyone that there's a little bit for everyone over here. I hope I delivered that. Yes, we all did that. So signing off, all of us. Thank you so much. Have a lovely time.
Thank you for the session. I think I really enjoyed. I don't usually, honest confession, don't enjoy panel discussions too much. But this was one where I wasn't sleeping. So thank you. Can I now request Dr. Aarti Vaknis, ma'am? Ma'am, could you please come on stage and felicitate all the speakers, please? Thank you, ma'am. Thank you to all the speakers once again. I would now like to call upon Ms. Mansi Karnad, Assistant Professor at SASLP, to proceed with the valedictory function.
Good evening, everyone. As we come to the close of the day, we are at the end of the Alumni Conference 2026, titled From Education to Professional Excellence, Alumni-led National Conference in Audiology and Speech-Language Pathology. I stand here with gratitude more than anything else. Over the last 2 days, we listened, we thought, we communicated. From research presentations to clinical stories, from old mentors to new graduates, this hall was filled with learning, nostalgia, and purpose. At this point, I would like to request some feedback from our participants and alumni. If there's anybody that volunteers, or, or I will call out names.
Thank you for arranging this conference so well. It is like I've mentioned earlier, today also I want to say the same thing. It is always, always, always very loving, happy moment to come back to BVP. It feels we are back home. We learn something, we create memories, and we go back and rewind our old memories. College has always known me as a cultural secretary, and hence again I was a part of the cultural committee. It was again wonderful to be there and presenting a talk here. For inviting me here also, I'm very thankful to my alma mater. And yes, the event was excellent. We enjoyed a lot and we did learn a lot. The speakers and the entire thing altogether was wonderful experience to be here. And not just this, we wait for the coming years for more alumni meets. And yesterday at the banquet, people were discussing, we all were discussing that the next alumni meet that we want, we are really looking forward for the 25th year of the college, and everyone wants to be more grand than this. So we are eagerly waiting for the next alumni meet. Thank you.
We have completed 20 years, but actually we were there from last 20 years. Okay, so from our batch, we were the first batch. We are your super seniors. So we have Sarang, Sunil, Rachana, Nikita. So 20 वर्ष झाले यार, म्हणजे वाटत नाही की पुण्याला येऊन 20 वर्ष झाले. म्हणजे हा this Katraj area was sunsan that time. Nothing was there, and only some action used to happen on the back market. Okay. Now, and it was, I'll tell you, like, teachers said it's fine. Now I'm professional. It was very boring. Okay. Initially, we had to arrange chairs. We were struggling for chairs. There was no table, nothing. We had to somehow, ma'am used to arrange table from some place and we used to sit. But it was fun. The only memory we had medical colleges.
There's a little opposition to your
So
witness.
they will appreciate how far they have come. AC was only in Bera room that time.
This can be a topic for our next conference, one of
So
the
this
panels.
conference, okay, I'll stop my description about my memories. This conference has been the second conference we have arranged by alumni, and I think this is the first of its kind in India that alumni are coming and talking. And 2 days were really wonderful, very wonderful arrangement. I do not believe that we had oral presentation also. In that 12 to 1, we had packed so many presentations. And I really thank the organizing team, all teachers. They have arranged it so well. I hope you like my singing yesterday night. So looking for singing in the next conference. Thank you.
I'm Shruti. Many of us must be knowing me. So here I would like to claim that I know Bharatiya Vidyapeeth inside out because I was a student, I was a staff, again I was a student, I resigned, I see Bharatiya Vidyapeeth from the other side, point also from the inside. So, and you all know that Sadanand's batchmate Sunil, like they are the first batch, so I am his wife, so I know all the histories of Bharatiya Vidyapeeth from his side also. Whatever I missed, it got covered, right? So in the whole of this journey, I think I have seen constant progress. Initially, I tried convincing my parents that this college is very good, I would try to. It was like at a peripheral level. But then when I really started being the team, now I can really, definitely you have got the certification, but then I think this is like one of the most like, it never stopped growing. Like you, any complaints you had, there was constant resolving of complaints, if it is a staff side complaints or from a student side. So as Sadanand said, as a student he would have had complaints, but then now at this point of time these students will not have those complaints. So there is constant improvement. Likewise, alumni, this particular thing we started with Vanaja ma'am, Aarti ma'am took it up, and now it is like, I attended both of it. I was like resource person in both of the sessions. So I can see that every single thing, aspect, it has improved in terms of auditory, in terms of food. So there is no complaint. Nobody can tell that this could have been better. I mean, last alumni, there could have been, you know, there were suggestions, but then now it has come to next level. So it is keeping on growing. So I'm very, very happy for this. I would say that we all should, I have told my friend, I was telling Nikita, we should keep clicking these photos till we became old age, right? Same type of photo. So we all should look forward and contribute. Initially when this was planned, I remember there was a discussion that too, why we should share our knowledge. Like usually resource person do get paid, right? So I would like to take up this. Why we should not, we should have got paid, and there was a discussion among juniors and seniors and everything. But I feel like this is like more of our homely thing, where we should utilize why we are standing here for whatever we are. It's only because of our basic thing is provided by them. Base is provided. We would have gone beyond that with our own efforts, but then it has been provided by our Bharatiya Vidyapeeth. So all of you guys, now you will become alumni soon. Like in few years, you will become alumni so soon. You will grow beyond your seniors, beyond your staff. So make sure that this particular event keeps growing until you get old age, until the Bharatiya Vidyapeeth is there. So that's our wish for, as senior batches, it's our wish for you that we all should stand together and make it a big success, and everything is perfect. Thank you, ma'am. Thank you for the staffs and students. Yeah.
I want to give my feedback. I don't know, like when I came PG to Bharatiya Vidyapeeth, before that I was the 3 months researcher coordinator with ma'am, CS Vanaja ma'am. Then I gave resignation and went to do my masters. I was trying for Aish, but didn't get that. Then came, joined in BBP. Believe me, the day I joined BBP, all my friends, everything, everybody, like we are doing MSLP. And believe me, that time our faculties are, some faculties are from audio background from ICE, or some faculties have a speech background from ICE, and they were expecting to do best in that. So our voice notes are like bigger than the ICE people as they're doing single degree also. We don't know the workload, voice is bigger, audio is also same. We were confused like what to do on that. So first batch, and when you do digitations on the part, ma'am was actually telling, okay, send three topics, we will decide your topics will decide the guide. You cannot decide the guide. So we gave a lot of in that. That day I give vestibular topic to ma'am. Ma'am said, change it. Well, ma'am, I'll do vestibular. And I remember that day ma'am gave me the freedom that, okay, if you want to do, then do, no problem at all. And I did my vestibular and keep learning, growing through this motivation from BVP that I can do something in different. And I'm really today very honored and privileged that being an alumni, it was my dream that I'll come to, I've told Nikita also one day, like, if BVP will call me, then I'll go and share my ideas about vestibular. So thank you so much to all the people who called me, especially Sharda ma'am once she called, Swarup, are you coming? Ma'am, alumni, no? Yes, I'm coming. So thank you so much, and I'm very proud, privileged for BVP's growth. I wish all the best, and I'll see all the new faces in vestibular. I'm requesting you, I'm requesting why? Because I have seen the struggle in vestibular. ENT people, neurology people are not thinking that audiology will come to this field. And we have opened a good, seat for us. We can sit, we can discuss with those ENTs, light-minded people, and we can do all these things. But when you are not coming, they are entertaining the physiotherapist and the other professionals to get into vestibular. So then after 5 years when you'll cry, nothing will be there. So that's my request. You do hearing aids, you do cochlear implant, no problem at all. But this is another horizon, another branch you can explore. And it's not one day journey. I took 10, 15 years. So you can take also another 5 years, because in my time now, laticals, no books are there. Now everything is available with you. Lot of professionals, lot of teachers are there with you. Please do. Thank you so much. Thank you so much.
Very practical feedback. Loved the conference. It was nice. To the management and team, I somewhere feel the next conference when we do, even if we increase the fees, somewhere we should employ an event management team. It was really difficult where we could not meet some of the faculties. Let's take it a very practical feedback. There were times where we could not meet some faculties also because they were all engrossed in making the events. So it will be a little easy for everyone, and they will be coordinating for the collection of PPTs and everything. Everyone is moving on delegating things. We should also take some team where they are cooperating for conferences. So that will be a little positive feedback that will ease out everyone's help. Okay, thank you.
Yeah, so we'll move on to the next thing on the schedule. A lot of people have contributed towards this conference for sure, and we are grateful for all their contributions. But there are some teams that did support us at the back end. And one of those teams is our finances. We had sponsors for our conference this year. And I would like to felicitate the sponsors now. I will be calling upon their names. I just want to make sure that we are ready. Yeah. Okay. So we will start with our platinum premier sponsors, Labat Asia Private Limited. Which are Thank you. Next is our gold sponsor, Advanced Bionics India Private Limited. Is there a representative for Advanced Bionics? Okay, we'll move forward to our silver sponsors, Allied Audiology, Universal Audiology and Hearing Private Limited, Medigadgets Technologies, and Sivantos India Private Limited. Is there a representative for Sivantos Private Limited? Okay, thank you. In the feedback, we had a lot of entries for the oral presentations, and now it is time to announce the winners for the oral presentations. I would like to invite Dr. C.S. Vanaja ma'am to hand over the prizes. Enter. Yeah. We will begin with the student category. Best paper speech in the student category goes to Joel Jain, Anjani Jain, and Ravi Patel. Please come forward. Are they not here? Okay. The best paper for language category goes to Moksha Shah, Lavina Vadvani, and Dr. Aarti Vaknis. Best paper Audiology in the student category goes to Jesna Joseph and Dr. Anuj Kumar Newpane. Best paper vestibular student category goes to Shreya Vivek, Anupratna Devi, and Christy Kraveri Datta. We'll move on to the professional category. Best paper speech in the professional category goes to Divya Shri KN and N Shri Devi. Best paper language in the professional category goes to Tanuja D and Kalpana R. Best paper Audiology in the professional category goes to my friend Ms. Christy Kaveri Datta and Dr. Shada Sarda. Congratulations to all the participants and thank you, ma'am. I would now invite our organizing secretary, Ms. Nikita Nanavati, ma'am, to come forward and extend a vote of thanks.
Good evening, one and all. As we come close to this enriching 2 days journey, it gives me immense pleasure to deliver vote of thanks as organizing secretary on behalf of Bharati Vidyapeeth deemed to be University, School of Audiology and Speech Language Pathology. First and foremost, I extend my heartfelt gratitude to our patrons, Honorable Dr. Padang Rao Kadam, Founder and Chancellor of Bharati Vidyapeeth, Dr. Shivaji Rao Kadam, Chancellor, Vivek Sauji, Vice Chancellor, Dr. Vishwajit Kadam, Secretary and Pro Vice Chancellor, and Dr. Asmita Jagtap, Executive Director of Bharati Vidyapeeth Health Sciences, for their constant support and vision that inspires every initiative at our institute. I would like to express my sincere gratitude to our principal and organizing chairman, Dr. Aarti Vaknis, for her leadership, continuous motivation and unwavering support throughout the planning and success of this conference. Her constant guidance, encouragement and meticulous attention to every detail played a very important role in ensuring the smooth coordination and overall success of the event. Thank you so much, ma'am. Now I also would like to thank Dr. Piyush Sone, Vice Principal and Treasurer of Alumni Conference, for his unwavering support throughout the conference. His constant guidance at every stage has been truly invaluable. He has been a pillar of support, extending his help in every possible way, from planning, coordination to execution, ensuring that every aspect of the conference carried out smoothly. Thank you so much. Now I would like to express my gratitude to Vanaja ma'am for her constant support, encouragement and invaluable guidance, which has been instrumental in shaping and strengthening this initiative of Alumni Conference. Her vision and foresight in conceptualizing and initiating the Alumni Conference 2 years ago laid a strong foundation for creating meaningful connections among alumni, students and the faculty. Thank you so much, ma'am. I would also like to thank Dr. Karmarkar, Principal BDU Medical College and his team for always providing us the necessary logistic help and for providing us this wonderful event venue for the 2 days conference. I would like to express my sincere appreciation to our Joint Secretary, Mr. Shahid Sheikh, for his valuable support and help in organizing this conference and his dedicated efforts, especially for coordinating and securing the sponsorship. My thanks to all resource persons for their invaluable contribution to this conference. Your insightful sessions, willingness to share rich professional experiences and engaging demonstrations were very good learning experience for all the participants. So I thank all the resource person for taking out your time and coming over here and sharing your experience. I extend my sincere thanks to all chair and co-chairs for your valuable role in evaluating the oral paper presentations. Also, I would like to extend my sincere appreciation to all committees for their dedicated contribution and coordinated efforts in making this conference a grand success. A special thanks to entire staff of SSLP for their tireless hard work, commitment and enthusiasm past over 2 months. Allow me some time, but I would like to go the committee-wise to thank each and every committee. So a heartfelt acknowledgement to scientific committee, specifically Pallavi ma'am, Rucha and Kalyani for their teamwork, coordination and meticulous planning at every stage, which helped the smooth organization and success of this conference. I also would like to thank Sharda ma'am, Sahil, Sunil, Isha, Kutsia, Shruti, Rachel, Nikita, Abigail, Amruta and Bhushan for their contribution. Now I would like to thank Finance and Budget Committee, Piyush sir, Shweta ma'am, Mansi, Shahid, Nihar sir, Pradhan, Nihar sir, Puneet, Pankaj, Mrudul and our accountant Sargar sir for their financial planning and resource management. Your constant effort for sponsorship made this conference possible. I would like to thank Publicity Committee, Megha and Ansia for excellent efforts in promoting this conference. Also, I would like to thank Sadanand, Simran, Arina and Rajkumar for their contribution. Thank you Inauguration Committee, Kuhu for organizing a graceful inauguration ceremony. Thank you Riyaz and Sneha for your help. Definitely yesterday's banquet night was a truly memorable, fun and enjoyable for all of us, isn't it? So I appreciate the efforts of Cultural Committee and Akshay for adding the vibrancy and enthusiasm for this event. Thank you so much. Also, I would like to thank Sahil, Aditya and Apurva for their contribution. I would like to thank Food Committee, Christy, Sejal, Mihir, Sudhanshu, Pratik, Ashral for ensuring the delicious food and excellent hospitality. My sincere thanks to Stage and AV Committee, Iram and Lisa for managing all technical aspects. I extend my gratitude to Venue and Stall Committee, to Anuj and Appas for venue arrangement and coordination with the companies. Also, I would like to thank Souvenir Committee, Vaishnavi, Madhumanti and Nidhi for their valuable contribution. Now, we are specially thankful to Labat Asia Private Limited, our premium sponsor, for their significant contribution. We also would like to appreciate the Advanced Bionics India Private Limited Company, our gold sponsor, for their financial support. Our sincere thanks to RF Electronics Private Limited, Allied Audiology, Universal Audiology and Hearing Private Limited, Medigadget Technologies, Medal India Private Limited and Civentos India Private Limited for their financial support and association for this conference. Thank you for providing us the finance. I express my heartfelt gratitude to all non-teaching staff, including mamas and maushis, for all your help. Your efforts behind this scene have been crucial to execute the smooth functioning of this event. I would also like to thank Medical College Canteen for serving us such a delicious food throughout the conference. Now, last and most importantly, I would like to thank all the participants, including our dear alumni, professionals, and students, for your active involvement, enthusiasm, and meaningful contribution that truly enriched this conference. Thank you so much for taking out time and joining us here. Thank you all for joining over here, and I wish all of you continued success in the field. Thank you.
Thank you, ma'am. Ma'am was really thorough with her vote of thanks, but there are two important people that we would like to felicitate for their hard work towards the conference. I would invite Aati ma'am to kindly felicitate our organizing secretaries, Ms. Nikita Nanavati and Mr. Shahid Sheikh.
I missed the registration committee, so I would like, which was the most important part, because they had started working from day one till now. So I would like to thank the registration committee, Rucha Palkar, Kalyani, Madhuri, Govind, and many other members. Thank you so much.
And with that, we will, before we formally conclude the conference, we will all rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all. Thank you for making this reunion meaningful, safe travels, and let's keep the conversation going until we meet again. Thank you.